This conference will now be recorded.
All right. So pediatric emergencies, um, something we don't deal a lot with, something we don't really see. If you look at book stuff, remember we talked about neonatals, newborns, right? Newborns for the first couple hours after birth, and then we go into about 28 days for neonatal. Then we get into the pediatric world, and pediatrics truly run uh, from the 1 year old mark until they turn 18 years old. They're still considered a pediatric. However, we start getting into the 16-year-olds, 15-year-olds. We're actually using adult medications for them. Once they've exceeded the Brazo tape, now we're into the adult meds. So we're going to start seeing a lot of that as well. But we don't see a lot of the 1 year old, 2 year olds, those sick kids very often. So those are the calls where where the focus really needs to be on that type of education, because we just don't do a lot of it. So let's start kind of move into this here. Hold on a second. Let me get past these competencies and start getting into the program itself. So pediatric emergencies account for a relatively small percentage, right? Small percentage of EMS systems call volume, because kids are not supposed to get really sick, right? Unlike adults, where we see the cardiac, the respiratories, with that small volume, right? We don't see that kid population for 911 calls. A lot of times kids fall down, they bounce, and they get back up again. For us as an adult, if we fall and hit the ground, we don't bounce. We kind of lay there and say, what the hell just happened? Right? And if they leave me alone for about 10 minutes, we'll get back up again. So assessment and management of infants and children present some unique challenges. It's not uncommon to experience anxiety when responding to a call involving a pediatric patient, because again, we just don't get enough of them. So ped patients, especially infants and small children, cannot provide the historic information that is usually easily to be attained from an adult. They just don't know, whether they can't talk, or they're too shy to talk about what's going on, or they just really just don't know much about what's going on in their own system, because the parents have all the information. And we'll talk about different techniques here in a little bit as well, on how to assess that pediatric patient. So be prepared to deal with parents or caregivers. So sometimes they provide vital information. Other times there may be a little assistance to you, depending on the caregiver who we're dealing with. Excuse me. So keep that in mind when we are talking. So children are not simply small adults. They have special needs that require assessment and management strategies, and how we're going to provide that assessment to that patient. When we approach an adult patient, we do a head-to-toe assessment. I've harped on that with a lot of people at work, and I harp with that a lot everywhere. Head-to-toe assessments need to be documented. They have to be done. That's how we're going to find problems. With a child, it's a little bit different, right? We have to start from the toes and work our way to the head. Reason being is we have to gain that trust, okay? We need to gain that trust of that child to allow us to make that assessment. Another thing we need to look at too as well is we need to get down to the same level. Some of us in the class are large, tall people that when they approach a kid, they tower over them. They're going to be scared. Get down to their level. Another thing that I noticed in other classes that I've taught in the past is, if I bring my daughter with me to the class and they do an assessment on her, the females in the class tend to assess the female pediatric a lot better than the male would do. And my daughter would then turn towards the female providers that were there doing the assessments, and it would work out better for them. When the male tried even taking a blood pressure, she would shy away and kind of migrate towards the female population of EMS providers. Whereas a male might do a little bit different, right? So keep that kind of stuff in mind as we're doing our assessments and looking at those management strategies. So communication with the patient and the family. You may have multiple patients to treat. Family members and caregivers often need help and support. If their kid is sick or really sick, the parents may become hysterical and they become another patient to you. Remember, we got to get them calmed down. So parents and caregivers may become angry or demanding. So a calm parent helps contribute to a calm child. So an agitated parent means the child will act the same way. They see that the parents are kind of freaking out and agitated. The child will probably do the same thing. So we got to keep that in mind as we're doing our assessment, is either to separate, and if we can't, we have to calm them both down. So explain everything you are doing to the patient in words that they can understand, if they are able to understand you, and explain everything you're doing to the child, to the parent, so that they know exactly what's going on. Remain compassionate, calm, professional, and when possible, allow the parents and caregivers to participate in the care of the child. There's nothing wrong with the parent putting on electrodes to do a 4-lead. As long as you tell them where it goes, I don't care how it gets on the patient, as long as it gets on, right? Let them help. It helps calm them and make them feel that they are making a positive contribution to the situation. It also allows the children who are not critically injured to remain on the parent or caregiver's lap as well. So, can you put this over their face for oxygen? Can you hold this near their nose? Incorporate the parents into this assessment, and that will make tremendous strides on your patient care. So let's go talk a little bit about lifespan development. I know we covered this before in chapter 9, but we need to do a little bit of a review. Okay, so infancy is the first year of life. We talk about the neonatal period, which is the first month after birth, I apologize. But we also have the newborn, which is not listed on this slide, but remember that the newborn is that period of like the first 5 to 6 hours after they've been delivered before they get into the neonatal phase. Now, remember that's for the first 28 days by book, but again, the first month, so it could be at the 31, right? So the first month of birth, and then 0 to 2 months, you got to keep in mind infancy, or 0 to 2 months, infants younger than 2 months spend most of the time sleeping or eating. They sleep up to 18 hours a day. Most, remember this is based on averages, and respond mainly to physical stimuli such as light, warmth, hunger, and sound. They should be easily aroused from a sleeping state. If they do not, it should be considered an emergency. Why aren't they waking up? They should also have a sucking reflex for feeding. So you can actually take your finger and put it near their mouth and see if they have a sucking reflex. And we want to make sure we have that, make sure they're able to feed. The head control, remember, is very limited, as they don't have those neck muscles and those chest muscles that really support all that. Remember, their head is proportionally larger than their body. They can turn their heads and they can focus on faces. They are really predisposed to hypothermia. Remember, there's low body mass. We have to keep them warm. Crying is the main mode of expression. Crying is good. We want to hear crying, right? They may cry when they're hungry or require other needs to be met, need to be changed, whatever it may be. If all obvious needs have been addressed and the infant is inconsolable, then that becomes a problem. Why are they not consolable by the parents? Right? As far as they cannot tell the difference between the parents or strangers. They don't know the difference between the two. And remember that they have those basic needs of being warm, dry, and fed. Right? Being held, cuddled, or rocked really does soothe the infant. Again, are they inconsolable? Can they not be calmed down? Hearing is well developed by that point. So remember, calm, reassuring talk is helpful in soothing the patient. So 2 to 6 months spend more time awake. They are more active and social. They recognize caregivers. Voluntary smiles and increasing eye contact are very common, and they begin to roll over. So by 4 months of age, infants are able to hold their heads up at that point. As they're able to roll over, we got to keep in mind that this is where we have the SIDS death, or the sudden infant death syndrome, at that age where they can actually take and roll themselves over and they can suffocate themselves or put them in, and become very hypoxic that way. So we got to keep that kind of stuff in mind as well during that time frame in 2 to 6 months. So healthy infants will have a strong sucking reflex and active extremity movement. They'll have that vigorous cry as well. So they may follow a bright light or a toy with their eyes or turn their head toward a loud sound or the caregiver's voice. So part of an assessment technique you can utilize for this, obviously, is your light on your phone, see if they can follow it. Pen lights are great because I can hand it to them and they can try using it, and you can see how their motor functions are working as well. Other things you can do is snap your fingers on each side of their head, not their head, but away from them, kind of make that snap sound, and see if they can follow that sound and that their head moves. And it's kind of interesting to see what that is. That's good. That's good. Checking their neural functions. Are they able to function appropriately neurologically by following those sounds and doing? Obviously, we can't make them do commands; they're too young. But can they reach out? Can they grab your finger? Right? Can they look at light? Can they follow the light moving and checking out their pupillary response, moving, and eye movement? So there are all different techniques you can utilize to help with that assessment of that pediatric. They have an increased awareness of the environment. They will use both hands to examine objects, which is what you want to see. This is part of a good neuro exam. Persistent crying and irritability can also be an indicator of a serious illness, because they should be able to kind of hold back on the crying by this age a little bit. But persistent crying and irritability, what's really going on? We need to do more of a thorough assessment. Lack of eye contact can be a sign of significant illness, depressed mental status, or delay in development. What's another thing that we can do as part of an assessment to check for dehydration in an infant? How's the question, you guys?
What is it? Check the top of the head.
Yeah. So what exactly are we checking, Sean?
Is it the fontanelles?
Exactly. 100% correct. Yep. The fontanelles. So we're checking the fontanelles. So if they are depressed, Sean, would that indicate dehydration or hypovolemia?
Dehydration.
Yeah, exactly. The dehydration hypovolemic patient with low fluids. If they're bulging out, what would that be? What would they be if they're bulging out?
Hypervolemia.
So if you find that they're bulging out, so okay, so like Tandra said, increased intracranial pressure. So we look for head trauma that way as well. If we see that bulging fontanelle, remember those fontanelles are located there because remember that it's the sutures are not fully put together, allowing for that opening for expansion as our heads as an infant are growing until we get to a full size head, as the sutures tend to form together and that fontanelle then goes away. So Tandra, you're 100% correct, intracranial pressure. From 6 to 12 months, they can sit unsupported. They can reach for objects. Crawling and walking starts kicking in at this point in time, which makes it even more difficult because they take off like a bat out of hell and they're gone. So we have to make sure we keep an eye on them. They want to explore their own bodies at this point, so they're more aware of their surroundings. The teething, and they're prone to picking up anything and placing it in their mouths. So risk for foreign body aspirations and poisoning. Also, with teething causes pain. So what is one thing that they can utilize to help with that pain? It used to be a New Hampshire protocol, but they took it away years ago, which I thought was horrible. It was a great thing to have. But what is something they can utilize to help reduce the pain?
Tylenol.
Okay, so you can use Tylenol, right? What else?
Ice.
Ice.
Whiskey.
So, I mean, obviously you have Motrin, Tylenol, the liquid stuff based on weight base of the patient medication. What's another thing that you can use, though? Anybody else want to try it?
about a little bit of whiskey?
I cannot promote that in this class, Sean.
Sean, get
And
out
the
of my
song.
head.
Oh, Tondra, I think you were blocked by Jen.
I just said, Sean, get out of my head.
So the other thing you can utilize is sucrose. Sucrose used to be actually a paramedic medication that was utilized in New Hampshire for many, many years. They took it away about maybe 8 years ago or so. So sugar actually reduces a lot of that pain too. So sucrose. So beginning the teeth and eating soft foods, babbling is now very common, and by 12 months they learn their first words. They may cry if they are separated from their parents or caregivers. Separation anxiety is very common, and persistent crying irritability can be a symptom, again, of serious illness. So the assessment of the infant at the child's appearance, remember we look at that pediatric assessment triangle, the PAT. Remember it's the appearance, work of breathing, and circulation, which are measured based on the PAT. And they respect also the caregiver's perception that something is wrong. So nonspecific concerns about a young infant's behavior, feeding, or sleep patterns may be tip-offs to a serious underlying illness or injury. So respect the caregiver's perception. Look at them. Ask them. Ask them about number of wet diapers. Have they been pooping okay, voiding, defecating, and what has been going on? Have they been vomiting at all? If they have been vomiting, how much have they been vomiting as well? It does not take much to dehydrate an infant. So when obvious reasons for crying have been addressed, persistent crying can be a sign of serious illness. So even though they spend much time sleeping, infants should easily arouse, and the inability to arouse an infant is considered an emergency. So by age 6, or sorry, by age 6 months, I should say, not 6, babies should make eye contact. So a lack of eye contact may be the sign of a significant illness or depressed mental status or delayed development. Infants approaching age 12 months are at risk for foreign body aspiration and poisoning. So crawling and walking also increase the exposure to physical dangers. Now you have things on the floor as well. They can run into stuff. Their balance isn't the greatest. They fall over. They can be injured. More head trauma than anything else. So crawling and walking. So consider the best location for performing a primary survey. Older infants may be comfortable with their parents' arms. So make sure that your hands and stethoscope are warm as well. They do not like cold. So make sure things are warmed up. Put them in your hands, warm stuff up for them, and then So be opportunistic with your examination. If the child is quiet, listen to the heart and lungs first, perhaps over the clothes. Right? They don't like having their clothes taken off of them. Right? If the young infant starts crying, let the baby suck on a pacifier or a gloved finger. Jingling keys or shining a pen light may distract an older infant as well. Or give them the pen light and they can shine it back at you. Work with them. And as you're doing that, you're actually checking reflexes. You're actually doing a neuro assessment just by having them hold things. Right? It's not just playing. It's actually doing an assessment. So explain each procedure to the parent or caregiver before you perform it as well. Let them know what you're doing. There we go. All right, so the toddler, ages 1 to 3 years of age, from 12 to 18 months. So begin to walk and explore their environment at this point. They're able to open doors, drawers, boxes, bottles. So with this, injuries can increase because of an exploratory nature and fearlessness. Hold on one second. All right, I'm back. So they're able to open those doors. So you got to keep in mind that they can get into stuff. So now it's time to start proofing the house. Begin to imitate behaviors of older children and parents. So they're looking at what they're doing first. So they also know the major body parts when you point to them and may speak 4 to 6 words. but may also not be able to fully chew their food, leading to increased risk of aspiration and choking. For 18 to 24 months, the mind is developing rapidly. So by 2 years, a toddler should be able to pronounce about 100 words. They're able to name a common object that you point to. So begin to understand the cause and effect as well. They begin to understand cause and effect of things. So balance and gait improve rapidly at this point, and running and climbing skills start to develop. Here they come. They start climbing everything. So running and climbing skills develop, and they tend to cling to their parents or caregivers and often have an object that comforts them when separated, more like a stuffed animal or something of that nature. So when doing our assessment, beginning the assessment of the toddler, we begin the assessment with the interactions with the caregiver, vocalizations, more mobility, measured through that pediatric assessment triangle. Persistent crying or irritability may also be a symptom of serious illness. So increased mobility at this stage, or this age group, increases their exposure to physical dangers and injury. So like I mentioned before, the pediatric assessment triangle, what are the 3 things that it measures? What 3 things do we utilize to measure pediatric assessment triangle?
Appearance, work agreement, and separation.
Good. All right, next. So examine the toddler in a stable condition on the parent's lap and allow them to hold important objects. As you can see in the photo here, you can see they're letting them hold the stethoscope. There's nothing wrong with that. It lets them feel what's going to happen, then explain to them. Even if you do things to yourself first. So put the stethoscope up to your heart, your lungs, things like that. Get down to the child's level and help gain that confidence and provide that toe-to-head assessment. So be creative when performing an examination on the toddler with stranger anxiety. Have a parent press on the abdomen to see if it appears painful. The parent can push, it's okay. And then once they allow that to happen, then they may allow you to assess the abdomen as well, or have the parent pull up the shirt a little bit so that way we can see the belly and look for any kind of bruising. Use play and distraction techniques whenever possible. Again, like holding a stethoscope, holding a pen light, as far as even taking one of your extra gloves in your pocket and blowing it up like a balloon, making a little animal out of it. Whatever it takes to kind of control that situation. They may be unhappy about being restrained or held for procedures, okay, as well. So offer limited choices when possible because they like to be in control. If you ask yes or no questions, the answer most likely will be no. They may also have a hard time describing or localizing pain. So consider performing the more upsetting parts of the examination last. Be flexible in your approach, right? So don't always have that whole toe-to-head assessment down pat. You may have to move things around a little bit on that assessment as long as you get everything. Versus as an adult, we have a systematic approach in how we assess. In a pediatric, we don't have that systematic approach anymore. Then we need to start low and work our way high. No longer requires shoulder rolls or to limit flexion of the neck when ventilating a bag valve mask or device or performing advanced airway procedures as well. So preschool age child, 3 to 6, can understand directions. They can be more specific in describing their sensations. They identify painful areas when asked, and risk of foreign body aspiration continues to be high because they can still put stuff into their mouths at this point in time. So with our assessment here, we're going to take advantage of the child's curiosity and desire to cooperate. If the patient is medically stable, offer to take turns listening to each other's heart and lungs. It's okay, they can listen. You know, it helps them learn, and it also helps you get that assessment done. Let the preschooler play or hold equipment that is safe, right? Don't just give them anything. Trauma shears would be a bad idea. Respect the child's modesty and only expose as much as necessary to complete the examination. Offer simple choices as well, simple things to them. Can you lift up your arms? Another good thing to check out neurological function is playing Simon Says with them. You know, and then you do it with them. Simon Says, put up your arms, put your arms by your side, put your arms out in front of you, lift one leg, lift the other leg. You can definitely do a lot of stuff. Yes, Justin, I just saw that IO drill. Honestly, though, not a bad thing as long as the needle's not attached to it. So there's different options that you can utilize with this. Avoid yes or no questions and tell the child what you're going to do before you do it. For the most part, you should be able to talk to a preschooler through an orderly, full body examination. All right, so for school age children, 6 to 12 years, begin to act more like adults. They think in concrete terms, they respond sensibly to questions, and they help take care of themselves at this point. They can understand the differences between emotional and physical pain. They have concerns about the meaning of pain as well, like why does it hurt? So give simple explanations, right? Don't go into the in-depth body system with a 6-year-old. They're not going to understand it. Well, some might, but most of the time they don't understand what you're talking about. I'm going to assess your abdomen. I'm going to assess your belly. You know, I'm going to look at your arm really quick. Can you show me your arm? Instead of going into forearms, I want to see your fingers versus saying, can you show me your phalanges? Right? So, not that we ever say that to any patient. But again, stay away, refrain from using those big medical terms with these younger kids. They don't understand them. Games and conversation may also distract these patients. There's nothing wrong if you're transporting a patient who is stable to take out your clipboard and play tic-tac-toe with them. That's fine as long as you have them on vital signs and you're monitoring stuff and the patient is doing okay, right? Keep them occupied. Reward the school-age child after completion of a procedure can be very helpful, saying, great job, you did a great job with that, thank you. Now we get into the adolescent. So most adolescents are aged between 12 and 18 years. They're able to think abstractly and also can participate in decision making. The adolescent years are when puberty begins and can be difficult. So struggling with the issues of independence, body image, sexuality, and peer pressure. So with an assessment, we're going to treat them as an adult. So address the patient, encourage questions and involvement, try to get as much information as you possibly can. Provide accurate information. Do not lie to anybody. Address concerns and fears about lasting effects of their injuries, especially cosmetic. Find out their interests. Get them to talk about them. Find out more about what's going on. And respect their privacy and modesty. If possible, address the adolescent without a caregiver present, especially about sensitive topics like sexual activity and pregnancy. If friends are on scene, the adolescent may want them to remain during the assessment. So let the patient have as much control over the situation as appropriate, but do not let down your guard regarding scene safety. Right? So they want to have someone there, that's okay. It's their choice. But again, if it presents an unsafe scene, then we got to make sure we're pulling away from that. All right, so any question over lifespan development? I know a lot of that's review. Everybody else good?
I'm good.
All right, perfect. Oh, one of the students just texted me. Stand by 1 second. All right, sorry about that. Just reply back to one of the students really quick. All right, so AMP. Remember that bodies grow and change very rapidly during childhood. So anatomic and physiologic changes and differences can create difficulties with your assessment of the child if you do not understand them. So a little bit about airway. So the airway is smaller in diameter and shortened in length. The tongue takes up more room in the oropharynx and can easily block the airway. And in the next slide, I'll show you guys some of the differences there. The epiglottis is a floppy, narrow U-shaped structure larger than an adult's at this point, because remember, everything's still starting to grow. The larynx is actually sitting higher and more anterior, and the trachea is smaller in diameter. So tracheal tugging can happen when experiencing respiratory distress, and where the trachea tends to draw into the neck. Right? What's another thing about the trachea that is different as well with our pediatrics? What is not fully developed on there? What are some things that are not fully developed on a pediatric trachea that we have as an adult? Yeah, cartilage. So the cartilageous rings. Perfect. The tongue takes up more. We talked about that as well. The trachea is definitely smaller. So the tongue can fall back. I'm looking at the picture here, as you can see. If you look at the airway there, not to mention the, a little too far in there, but in this area here, the cartilageous rings are not fully developed, which can allow the trachea to kind of crush on itself to push in, versus an adult where we have more cartilage rings through this area here that will allow it to stay open. So if you have a infant getting into the child where we have to pad the shoulders underneath here, as you can see the differences compared to an adult in this area versus this area here, as a child doesn't have the muscle buildup in this location as an adult does, their head and neck will tend to go in a downward direction, causing the trachea to fold over. So pressure on the abdomen can block the movement of the diaphragm as well as cause respiratory compromise, and young children also experience muscle fatigue quickly, leading to respiratory failure. 95% of the time, it's a respiratory issue that causes cardiac arrest in a child. So let's try to catch it quickly in that respiratory part. Remember, infants use their diaphragm rather than their chest muscles during inspiration because there isn't much chest muscle there in an infant. It's still developing. So tissues of the lungs are also more fragile, and the ribs are more cartilaginous as well. So substantial compression injuries to the chest may injure vital interthoracic organs. Respiratory muscles as well in a child are also more immature and fatigue more quickly than an adult does as well. The mediastinum is more mobile than an adult, and the functional residual capacity is also smaller, resulting in proportionally smaller oxygen reserves. So they can become hypoxic a lot faster, right? And what is the one thing we've always learned about pediatrics? They can compensate and compensate and compensate for so long And then what happens? Yeah, rapid deterioration. I'm going to need to start hearing from some other people in the class, by the way. I noticed that I'm not hearing from many people. So some people need to actually step up and start talking or putting it into the chat box. Know that I know you guys are actually here. All right. So this table 36.1 shows the pediatric respiratory rates as well. These are things that you should really know. Kind of the basics from adult, child, and infant. So our infant should be 25 to 50, 15 to 30 for child, and 12 to 20 for adults. That's kind of like the basic range we're looking at. But get used to some of these ones here. I'm not saying to memorize every single one of these, but kind of have an idea of where these ranges are to make sure we're actually hitting those numbers to find out if someone truly is in a respiratory distress. If you have an infant that's breathing, 50 times a minute, that's perfectly fine. It's a little on the higher end, but it's still within that normal range. So we don't want to have to start treating that. But we start seeing going too fast, like 80 or 90. And I've seen this happen before with sick kids with fevers where they're breathing 90 to 100 times a minute. And these things need to be controlled. That'd be truly tachypnic for these patients, along with significant tachycardia. With a fever, they could be septic. And it does not take long for that bacteremia and sepsis to get through the entire system to cause a infant to be going to septic shock and become significantly dehydrated. So again, we got to pay attention to these. These are important indicators in a sepsis or an infection to see if it's progressing into a septic, the sepsis world, right? So again, know these numbers. I memorize every one of these may be tough. Some of you might be able to do that, some may not. But have these ranges. And it's not a bad idea, since we don't deal a lot with pediatrics, to have a little quick cheat sheet, right? They do have those out there. You can buy a little card they can attach on the backside of your ID tag, and it has all your pediatric vital signs listed on there. So I do have a couple as well. Where I put them, I do have them somewhere. And if I can find them, I'll give them out to you guys on Sunday. I just got to locate where I put them. So gastric distension results in hypoventilation as well, and increased risk of regurgitation with aspiration. So why would gastric distension result in hypoventilation? Why would that happen? Why would gastric distension result in hypoventilation? Yeah, less space for breathing in, because now we're pushing up underneath that thoracic cavity, right? We're pushing up against the lungs, giving it less space to breathe. So until the age of approximately 4 to 6 months, infants breathe through their nose as well. So remember, keep the nares clear in infants younger than 6. So even if they take suctioning, put it on low suction and suction their nasal passages, you can do that. And avoid hyperextension of the neck. Remember the tracheas are more pliable, they can bend. Keep the airway clear of all secretions if you have to use suction or a bulb syringe, depending on the age. Keep in mind that if you are suctioning and you're suctioning an infant with the suction units on the truck, you can't suction for long periods of time. You're going to pull their oxygen away from them, right? So you got to reduce that time and suction what you need to suction and take it out, right? Use care also in managing the airway, because they're very small and they can become occluded very quickly. So infants and children are also highly susceptible to hypoxia because of decreased oxygen reserves. So they can become hypoxic, increase oxygen demand, easily fatigued respiratory muscles. They also use a larger bag. So use a larger bag to ventilate a pediatric patient if needed. There's only enough pressure to achieve visible chest rise. Any more than that can cause barotrauma, causing any more thorax. So who can go? Which one of you guys would like to explain to me why, or what would happen, or signs and symptoms, I should say. What are the signs and symptoms of a patient who becomes hypoxic? And then tell me, and then go a little more in depth with it on top of that. So someone may have to unmute to kind of explain it. I'm kind of curious and see where your train of thought is going when I say highly susceptible hypoxia, and if they are hypoxic, what is going on inside the system and how could we fix it? And how do we recognize it other than just pulse oximetry?
Cyanotic lips and stuff.
Okay, so you got the cyanotic lips. Keep going with that, Kenny, though. So you see cyanosis, right? And you say, okay, this kid is sick. What else are you going to pick up on as well?
What do you call it? But say like breathing between the rib cage.
Okay, so seesaw breathing, is that what you're looking for?
Yeah.
Well, and intercostal retractions.
Yeah.
Okay, what else would you see? How about vital signs? Who else wants to try that one there? What would you see for vital signs? Okay, so Mike's saying tachycardia. Yeah. So we're going to start seeing that change for that oxygen demand, for that low oxygen reserve, right? So we got to look for those numbers. You got to see that increase. We got to look for that tachypnea, tachycardia. And a lot of sometimes you'll actually see bradycardia in patients, in infants. You'll see the opposite, that bradycardic event that would say lack of oxygen. So can we fix it? Can we fix bradycardia with oxygen on an infant? Yes. Yeah, that we can. Right. So we got to give them that oxygen and assist with their ventilations as well, trying to control that drive and give them the oxygen that they need. So we can utilize the BVM and give small little squeezes of oxygen, like it says, a larger bag to ventilate, right? So we put the BVM on them, and as they're breathing, we give a little squeeze. You don't have to get some oxygen into the system to help offset that decreased oxygen reserve that they have to reduce their heart rate or increase their heart rate, depending on which part of their compensation they're in, and bring down that tachypnea into a normal range. And then in turn, we'll then relieve what Kenny had mentioned, relieve some of that cyanosis, okay? And then if we leave the cyanosis, then our pulse oximetry starts to come back up. And yes, you can still use end-tidal on infants. We do carry those as well. Matt, I see you're unmuted.
Oh, look at that. I'm unmuted. Hi.
Hi, Matt. I don't know if you're going to say something. I saw you unmute.
No, I'm listening and trying to get ready to go to Conway.
That sounds like a blast.
Yeah.
All right. Sorry about that. So looking at here, children rely mainly on their heart rate to maintain adequate cardiac output. Their heart rate means a lot. So know the normal pulse ranges when evaluating a child. An infant heart rate can be 200 a minute or more if the body needs to compensate for an injury or illness. We can see that change. An infant cannot tell you they hurt other than they cry, but can you see pain level in heart rates? Do you think you can see it? Do you see the changes in vital signs of someone who's in pain? Yeah, exactly. 100% yes. So look at these numbers, okay? All these over here. Look at them all. Okay, awake versus sleeping. There's a difference. We got to make sure we understand those, right? And if they're not easily arousable when they're sleeping, that could lead to a bigger problem. So children have a larger circulating blood volume than adults. So the absolute blood volume is less than approximately 70 mLs per kilogram. So the ability of a child to vasoconstrict provides the ability to keep vital organs well perfused. Injured children can maintain their blood pressure for longer periods than adults, even in shock, which is why you have to do a very thorough assessment. Proportionally larger volume of blood loss must occur in children before hypotension develops. So suspect shock in an infant or child presents with tachycardia. Okay, we have to look for the other vital signs. You've got to be vigilant looking at the heart rates. This is why it's so important with any trauma patient, whether it be an adult or pediatric, it does not matter. Put them on a cardiac monitor. That'll give you live rhythm, live heart rate. Okay, as an advanced EMT, put them on the cardiac monitor. Do a 4-lead. and monitor that heart rate. Put them on end tidal. Monitor their perfusion if they're willing to, if they'll keep it on. All right. Look at their blood pressure as well. Even though you're not going to see blood pressure changes, but still run them. Right. Remember I mentioned before about bradycardia? In a patient who is severely hypoxic, you're going to see the patient become bradycardic. Hypotension often indicates impending cardiopulmonary arrest as well. So signs of vasoconstriction include weak peripheral pulses, delayed capillary refill in children younger than 6 years of age, and pale, cool extremities. So if you walk in and put them on a cardiac monitor and their pulse oximetry is low and they're bradycardic, these patients need to be ventilated quickly. All right. If not, hypotension will start kicking in and they'll go into cardiac arrest. Remember, if a heart rate is less than 60 on a pediatric, what do we do on an infant?
Resuscitation.
Yeah, CPR. So infants, unless heart rate less than 60, we start CPR, right? Because that heart needs that assist. I'm not saying defibrillation, but CPR to help move the blood, get the heart rate back up again as we oxygenate, and hopefully in turn that'll change some stuff. All right. So as far as the nervous system goes, the brain and spinal cord are not very well protected. Not as an infant. So neural tissue and vasculature are very fragile and easily damaged, and also susceptible to bleeding from injury. The subarachnoid space in a child is also smaller than an adult as well in the brain. And bruising and damage to the brain may be the result of head momentum. So you got to keep that in mind when we're doing our assessments. We got to make sure that they can grip, they can look, they can follow commands. As the older they get, you can start getting more into your stroke assessments as well. But as a kid, you got to check different reflexes. We'll talk about those here in a few minutes. The brain requires nearly twice the cerebral blood flow as an adult. So head injuries are greatly exacerbated by hypoxia, hypotension, or causing ongoing damage. So how can we measure cerebral blood flow? How can we measure that in the field to make sure we're not constricted or dilated? Again, not end all be all, but what can we utilize to help measure that? Any thoughts? How can we measure if a patient is vasoconstricted or vasodilated in the brain? Tondra, you are 100% correct on that, what you just sent to me. So if you want to bring it to the rest of the group, you can.
Sorry, JP was playing with my computer and I didn't realize that it wasn't going to everyone.
It just went to me. So,
But I said end tidal.
end tidal. Hyperventilation and hypoventilation of a patient can cause constriction and dilation. So we can, I'm not going to say we're going to measure that, but we can kind of see where it sits based on the patient's respiratory drive. Is there too much carbon dioxide or too little? And the way to fix that is manage the ventilations based upon end tidal, keeping it between 35 and 45. So 40 is a good number. So Tondra had that 100% correct. We got to put them on end tidal. You got to monitor that, whether that be through a BVM or the nasal cannula. Either way, we have to find a way to measure that and monitor it. Also, spinal cord is obviously less common for spinal cord injuries. For musculoskeletal system, bones are softer and more porous until adolescence, which means that they can bounce, but also makes incomplete fractures, or what they call the green stick fracture, more likely. So treat any sprain or strain as though the fracture does exist, because if it does hurt and looks like it's sprained, it could be a green stick fracture, and immobilize it, the injury accordingly based on your protocols. Injury to the epithelial plate during development or puncture of the growth plate during interosseous cannulation may also result in abnormalities in bone growth and development, which is why it's so important to know your landmarks when you drill a patient. Very, very important, especially in kids. You don't want to have an abnormal growth plate, because it can actually change their height differences and everything else based upon legs. Bones don't grow like they're supposed to, right? So we want to make sure we stabilize, and if we're going to drill, know where you're drilling. Know your landmarks before you do it. If you're not sure, I'm not saying look up YouTube on a call, but you should know, you really should know what you're drilling into and where to go. Remember that the heads are proportionally larger than in adults as well, so infants may experience excessive heat loss as a result. So wrap the head up, keep them warm. During infancy, the anterior posterior fontanelles are open. They both close approximately 18 months. So infants and children are especially prone to head trauma. So we look for that, look for that fontanelle, for that bulging fontanelle for intracranial pressure or significant hypovolemia and dehydration. So special care must be taken when positioning a child's airway. So if the child is younger than 3 years of age, place a thin layer of padding under the shoulders, like I mentioned in that other picture when I circled it, to keep their head in shoulders or back obtain a neutral position, like inline position, to keep that trachea from closing. And in seriously ill children older than 3 years of age, place a thin layer of padding underneath the occipital region of the head and a thicker layer of padding under the shoulders and upper back to obtain a sniffing position. So the occiput, the occipital region of the head, which would be the backside. We talked about fontanelles. So bulging suggests increased intracranial pressure, and then hypovolemic or dehydration in the sunken would suggest this. All right, so the gastrointestinal system, abdominal musculature is immature and often less protection, and offers less protection to solid vascular organs such as the spleen and liver, proportionally larger and more vascular. So the abdominal organs are closer to one another as well. So everything's more compacted inside. So the pediatric patient are a higher risk for splenic and hepatic injuries than an adult, being the spleen and the kidneys, being the hepatic injuries. So multiple organ injuries also are more common. As far as the integumentary system, the skin, infants and children have thinner and more elastic skin, larger body surface area to body mass ratio, and they have less subcutaneous tissue or fatty tissue. So these factors can contribute to increased risk of injury following exposure to temperature extremes. Risk of hypothermia can complicate resuscitative efforts and dehydration, and severity of burns also. So burns may be classified as minor to moderate in adults, are classified as severe in children because they don't have that fatty tissue and everything else built in it at this point in time. They're so small and so young, right? So things will actually tend to be worse off for these kids in burns, hypothermia, just because of the body mass as well. Some metabolic differences. Obviously, infants and children have limited stores of glycogen and glucose. So rapidly depleted as a result of injury or illness. If they get sick, if they get injured, they can actually drop their blood sugars. So infants and children are highly susceptible to hypothermia, and a risk of hypothermia is further increased due to larger body surface and mass ratio, which then gives them the lack or the ability as well to shiver. So they may be cold, and they don't know they're really cold, and you can't pick up the fact that they're actually severely cold or hypothermic because they're not shivering. So again, kids that are outside, warm them up. Significant hypovolemia or electrolyte derangement are more common due to severe vomiting and diarrhea. So keep the child warm during transport, prevent loss of heat or body heat, including covering the child's head. And newborns should not be overwarmed because this can also worsen neurologic outcomes as well. If a patient has hypovolemia, what are we going to do to treat them? IV. And what is going to be our fluid administration? How do we know how much to give? Remember, we're past neonatal phase. What was that?
Can we give ringers?
I would hold off on ringers in pediatrics for right now, and stick with saline. If you're going to give ringers, and contact med control for that. We don't want to completely flood them with electrolytes. So Justin said 10 mLs per kilo, which is correct if you're giving it to a neonate. Now let's get into the pediatrics.
So would that be 20?
20, exactly. Yep. So Justin, you had it right for neonatal resuscitation, but for pediatrics it's 20, adults is 30 mLs per kilo. So look at that 20 ml per kilo administration. Now we talk about giving boluses. Okay, this is what we're doing to help with that electrolyte derangement and also with that hypovolemia. The best way to do it again is through a 3-way stopcock, and I'll show you guys how to do that again. I think Laurel did that with you guys in the last time you did practicals. And it's something you should be very familiar with, especially pediatric assessment, since that is one of your skill stations, pediatrics, is to how to pull fluid through a 3-way stopcock into a syringe and administer the bolus, so that way there it's accurate. And we're going to cover more of that as well as we move forward. So let's get through these here, and then we'll take a break through this section. So scene safety. So observe for any hazards, potential hazards. Resist temptation to hastily approach a patient if you know it's a child. Right? Approach your patient, get down to the level, and have a conversation. Assume the mechanism of injury was significant enough to cause head or neck injuries if no other information is possible. Index of suspicion for abuse should increase when there is conflicting information from the parents or caregivers. I'll give you a scenario that I had once, and you can tell me whether or not something wasn't right. Okay? And I want your honest opinion on it. You get called to a residence for I want to say it was like an 8-year-old patient with a leg injury. I get on scene, and the parents are not frantic. They're not even attending to the child. The child is sitting cross-legged on a couch with an obvious femur fracture, mid-shaft. I could not straighten it. I could not help the kid at all. He would not move his leg, but he had good pulses. Vital signs were stable. I asked the parents, what happened? They said the dog sat in his lap. Kid has no indication of any kind of bone disease or anything else. Obvious femur fracture, mid-shaft. Extreme pain, and they could not straighten the kid's leg out. I ended up giving him fentanyl to reduce the pain level down and transported him to Maine Medical Center in Portland. Would you think there's a high index of suspicion for abuse on that? And if you think it is, why do you think it is? Right, indifference in caregiver. Anybody else want to chime in on this? Does anybody else agree with Tandra's assessment? The injury does not match. You're right, Rosa. That did not match. Right? The parents did not want anything to do with the kid at all when we were there. It was hesitant to even talk to us. We're in another room. This poor kid sitting in pain. Things just didn't match up. Like Tandra said, indifference in caregiver. Justin, yes. Rosa, yes. Not a tentative or seemed concerned. They had no concern whatsoever that this kid's leg was broken. I did file a complaint. I did file for abuse as well, and it was looked into. I don't know the outcome. They never actually told me when they probably should have, but I know that it was submitted by the hospital staff and by me for that. Again, and I as much as you wanted to take out the parents, you had to play it off. Just treat your patient, get them out, get them into the back of the ambulance. They never even went to the hospital until like 4 or 5 hours later. It was that bad. Like the parent, I talked to the ER staff, confirmed femur fracture, and the parents never showed up for like 5 hours. So something to think about. Pay attention. Index of suspicion is huge. What do you think? What do you feel? Conflicting information. Bruises or other injuries that are inconsistent with MOIs described. Look for those different patterns of the bruising as well. Where they're located, are they different colored? Injuries that are inconsistent with the child's age and developmental abilities. And observe and note the parents or caregivers' interaction with the child. So again, like I mentioned, they had no interaction. They didn't care. So your objective to identify and treat immediate and potential life threats is part of your primary survey. That's your objective. Perform C-spine mobilization if the MOI is severe. Pat under the patient's head or shoulder for airway management. When assessing the pediatric patient, use the PAT to form a general impression. Right? So look at the structured assessment tool that allows you to rapidly perform a general impression without touching the patient. It should take 15 to 30 seconds, conducted prior to assessing ABCDs. This does not require touching the patient. Literally, it's a visual assessment. All right. Provide a first glance assessment to identify any general category, to identify the general category of the child's physiologic problem and establish urgency for treatment and or transport. The three elements are the appearance, so that's be the muscle tone and mental status, work of breathing, and circulation to the skin. Take a quick look and look at it, and then document. PAT showed this in your narrative, right? So we look at the appearance. Let's kind of go over the PAT really quick. Appearance, we look at the Tickles mnemonic, right? Which I'll go over here that in a second with you guys. Well, actually, it's in front of you. Sorry, I didn't see that over there. I was looking at something else on the screen. So tone, interactiveness, consolability, look or gaze, speech or cry. So that's part of our appearance. Looking at that Tickles, TICLS mnemonic. I guarantee you're going to see this on your National Registry exam in pediatrics. So take note of this. The most important factor in determining severity of the illness, need for treatment, and response to therapy is the appearance, which reflects adequately the ventilation, oxygenation, brain perfusion, body homeostasis, and central nervous system function. That's why we use that Tickles mnemonic. Tone, interactiveness, consolability, look or gaze, speech, and cry. So observe the child from a distance, allowing for interaction with the caregiver. Delay touching the patient until you have developed your general impression. That's sick or not sick. Which way are we going to go? Unless the child is unresponsive or critically ill, take the time assessing general impression by observation. A normal level of consciousness characterized by age-inappropriate behavior or interactiveness, poor muscle tone, or poor eye contact will with you or the caregiver will indicate a significant critically ill patient. Let me look at the work of breathing. This reflects the attempt to compensate for abnormalities in oxygenation and ventilation. So a good measure for effectiveness or gas exchange as well includes listening for abnormal airway sounds and looking for signs of increased breathing effort. Increased work of breathing, tachypnea, abnormal airway noises, retractions of the intercostal muscles or sternum in patients' positions will help with this as well. There's nothing wrong, which is not added to here, to throw on end tidal really quick and kind of get a reading and monitor that respiratory rate if they will tolerate it. That's the thing. If the infant will not tolerate that, they'll take it off. But they do make pediatric nasal cannula ones for the cardiac monitors. Then we look at circulation to the skin. As you can see, that mottled skin, you can see the difference in colors here, looking at the legs, that paler skin. So it reflects overall status of core circulation. So consider paler, mottling, and cyanosis. This would be more of a mottling deal, which means this kid has poor perfusion. So pallor of the skin and mucous membranes may be an initial sign of poor circulation or only a visual sign of compensated shock, which may also indicate anemia or hypoxia. Mottled skin is caused by constriction of peripheral blood vessels. Cyanosis is the most extreme visual indicator of poor perfusion or oxygenation, as we see that bluish color. So this looks a little bit blue in here, that bluish color there, a little bit right in that area. So right there and over here as well. This looks like on my screen anyways. So if you start seeing those discolorations, these patients are considered critical, and we need to make sure we're getting them the appropriate treatments. Acrocyanosis, or blue hands or feet in an infant younger than 2 months, which is a normal finding when a young infant is cold. True cyanosis is a late finding of respiratory failure or shock. So never wait for development of cyanosis before administering oxygen. If they appear to be not perfusing appropriately and not getting the oxygen that they need, then give it to them, even if you don't have that cyanosis yet. So stay or go. If the patient is unstable, assess ABCDEs and treat any life threat and transport immediately. If the patient is stable, continue with the remainder of the patient assessment process and work on your toe-to-head assessment. So hands-on ABCDEs would be assessment of the vital functions, airway, breathing, circulation, disability, and exposure. So treat any immediate and potential life threats. If you suspect cardiac arrest, the order is C, A, B, D, E. Compressions, airway, breathing, disability, exposure. An assessment may also require modification based on the age of the patient. So with the airway, if the infant or child is responsive and the airway is open, assess respiratory adequacy. If the child is unresponsive, ensure the airway is properly positioned and is clear of mucus, vomitus, blood, and foreign bodies. Trauma, if it's ruled out, you can do a head tilt chin lift. If trauma is involved, do the jaw thrust maneuver to open the airway. Those steps are in skill drill 36.1, position airway in a pediatric patient without trauma. So you look in your books for those. So as you can see, the top picture up here, that's a head tilt chin lift and jaw thrust maneuver. When the airway is open, ensure that it is clear of potential obstructions. If there's an obstruction, we suction it out and we continue moving forward. Right. So establish whether the child can maintain the airway spontaneously or whether adjuncts will be necessary to maintain adequate airway patency. With breathing, you got to calculate the respiratory rate, auscultate breath sounds, listen to all fields of the lungs, check pulse oximetry for oxygen saturation. And one thing that should be added in this as well is check end-tidal CO2. Note the degree of air movement in and out of the nose. Determine whether the chest is rising adequately and symmetrically. Is it different? Do we have asymmetrical chest rise? Are they breathing in a seesaw motion for severe respiratory distress? We're going to assess respiratory rate and effort, so rate, rhythm, and quality, and listen for abnormal respiratory sounds and note the signs of increased respiratory effort. And then we need to start making our adjustments to start treating that. Remember that patients go into respiratory arrest before cardiac arrest, especially in kids. Usually it's a respiratory issue. As a child begins to tire, retractions often become weak and ineffective, right? So slow respirations is an ominous sign indicating impending respiratory arrest. So do not mistake a sign of improvement. Be prepared to ventilate quickly if you start seeing this happen. Just because the respiratory rate is coming down does not mean that it's fixed. It could be going completely the opposite direction where they go into respiratory arrest. So we want to make sure we're treating this effectively, right? And start ventilating for them. Let me check our circulation. So first, control any active bleeding. If the bleeding out, there's nothing we can do past that point. We got to stop that bleed. right? We're going to assess the pulse rate, rhythm, and quality, skin, capillary refill time, and blood pressure. In infants, palpate a brachial pulse or ephemeral pulse. In children older than 1 year old, go for the carotid pulse. All right, so as you can see here, they're checking brachial, femoral, and then carotid over here. So note the rate and quality of the pulse. Rate, rhythm, and quality. Is it bounding, slow, fast? How fast it's going? Numbers, like how, like, 100 beats a minute, 200 beats a minute. And then looking at the quality as well, and then the rhythm. Normally, in a pediatric assessment, the heart rate should be regular as a rhythm, which is why they don't add this to the assessment, but it should still be part of it. Weak or absent peripheral pulses indicate decreased perfusion. Okay, so weak central pulses indicate significant hypotension and decompensated shock. So if they have a weak central pulse, we're in decompensated shock at this point. We need to make sure these patients are getting fluids. We got to bring this back up. Tachycardia may be an early sign of hypoxia or shock. Then we get the late sign of hypoxia being bradycardia. The absence of central pulses, that is brachial or femoral in infants and carotid in older children, indicate immediate need for CPR. Interpret the heart rate within the context of overall history of the patient, PAT, and the entire primary survey. Get them on a cardiac monitor. This is now talking as the local stuff that you guys would use like the state protocol. Get them on a cardiac monitor so you can start monitoring their rates. So a trend of increasing or decreasing pulse rate may suggest worsening hypoxia, shock, or improvement after treatment. Right? So just because it's getting better doesn't mean it's not going to go to the other end of the spectrum. Okay, so you've got to keep an eye on that. Feel the skin for temperature and moisture while you assess the pulse, and estimate the capillary refill time by squeezing the end of a finger or a toe for several seconds, then observing the return of blood to the area, as you can see in the picture above. The color should return within 2 seconds when you let it go. This is used to assess end organ perfusion, right? Most reliable in children of younger than 6 years old, may be affected by cold temperatures. So again, you need to warm them up. If you're cold and they have cold extremities, you're going to have a slower cap refill time, even though they might be perfusing okay. So we got to warm them up. If we look at our disability, the ABPU scale or the pediatric Glasgow coma scale to assess level of consciousness. All right. And then we're going to check responsiveness of each pupil and to a direct beam of light, looking for pupil reactivity. Then we have to assess their pain. Now, if they don't have a pain scale, we can use something called the Wong-Baker scale, which is you can see here, 0 through 10. So note any neurologic motor deficits. We need to make sure we're doing a decent assessment, especially in infants. We look for what they call Babinski reflex to check neurofunctions. That would be rubbing a object through their feet from heel to toes to look for either curling or spreading formation of the toes. Would indicate either a neurological issue or not. Right, toes should fan out, not curl in. So look for the symmetrical movement of the extremities. Note any neurological motor deficit. And then again, the Wong-Baker scale definitely helps when documenting your assessment. Exposure. So the PAT requires that the caregiver remove part of the pediatric patient clothing to allow observation of the face, chest wall, and skin. Be careful to avoid heat loss, especially in infants, and keep the temperature in the ambulance high and use blankets when necessary. Okay. We don't want to make them too hot. We got to make sure we keep them warm though. As far as transport decisions goes, if the child is hemodynamically stable, you may elect to perform a secondary assessment at the scene. So immediate transport is indicated if my computer charger the scene is unsafe for the child. There's a significant mechanism of injury, a history compatible with a serious illness, a physical abnormality noted during the primary survey, a potentially serious anatomic abnormality, significant pain, or level of consciousness that is not normal for the pediatric patient, altered mental status, or any signs of symptoms of shock. These are going to be our rapid transports versus our stay and play. This would be more of our load and go. So when making a transport decision, consider the type of clinical problem you have, expected benefits of ALS treatment in the field, treatment and transport protocols, your comfort level, and transport time to the hospital. If a patient needs an IV, don't delay, do an IV. Right? Don't be afraid to put an IV in a pediatric. It needs to be done. Right? If needed. Right? Do not delay it because of your comfortability and say, oh, I don't feel comfortable putting this in. We're 20 minutes from the hospital. Right? If this kid needs a line, 2 attempts of an IV or 90 seconds of looking, we have to go to an IO and start administering the fluids we need to administer. Right? So on Sunday, we'll kind of go over more in depth on pediatric IVs. I will cover that with you guys as well, and then topic discussion on different locations you can look for to find the site. If the child's condition is urgent, initiate immediate transport. Remember, the back of the ambulance is our hospital. Okay, that's our office space. So conduct additional assessments and treatments en route. If the child's condition is stable, perform a secondary assessment at the scene, provide additional treatment as needed, then you can transport to the hospital. Unnecessary use of lights and sirens may increase the anxiety of the child, parent, or caregiver. Remember, so flow of traffic, unless it's a status 1 patient, we shouldn't be going lights and sirens anyways. Pediatric patients weighing less than 40 pounds who do not require spinal mobilization should be transported in a car seat as long as the situation allows you to do so. So use a proper immobilization device if the patient's car seat has been damaged. So to mount a car seat to a stretcher, right, we're going to place the stretcher in an upright position, place the car seat so it is against the back of the stretcher, secure one of the straps from the upper portion of the stretcher through the seat belt positions on the seat and strap it tightly to the stretcher itself. Repeat on the lower portion of the stretcher. Push the car seat into the stretcher tightly and retighten the straps. Follow the seat manufacturer's instructions to the car seat and then to the captain's chair. So we can practice putting these on. I do not have another car seat, but if someone has one they want to bring in for Sunday, we can also practice putting car seats on stretchers as well. I just don't have one now anymore. I've got rid of mine. It's not appropriate to secure a pediatric patient in a car seat when the patient has to be immobilized on a longboard, requires splinting that does not fit the car seat itself, if unstable and requires airway or ventilatory support, or is in cardiopulmonary arrest. So with history taking, we're going to provide emotional support. So when speaking to the child, use appropriate terminology. Remember, keep it down to their level. When speaking to a parent or a caregiver, use simple, non-medical terms so they understand what you're looking for. Allow sick and injured children to express their feelings. How do they feel? Right? Don't make an assumption for them. If they can speak and provide you that information, let them tell you how they feel. We're then going to investigate the chief complaint by using our approach to the history will depend on the age of the patient. So how are we going to approach the history that's there? Historic information for infant, toddler, and school-age child will have to be obtained from a parent or caregiver. Sexual activity, possibility of pregnancy, or illicit drug or alcohol use should be obtained from an older adolescent patient in private. So try to separate them from anybody else. Assure the adolescent that this information is important, and needed to provide the most appropriate care. Remember, so when questioning the patient or the child about the immediate illness or injury should be based on the child's chief complaint. So what is wrong with what is going on? Why are we here today? So when interviewing the parent or older child about the teeth complaint, obtain the same information you would as an adult. Sample, OPQ or STI, get all that information. Ask if the child is currently under the care of a physician. Who is their pediatrician? Are they seeing one? If they're young enough, how has the postnatal care been, especially they're in the neonatal phase? If the patient or caregiver is unstable to accompany you to the hospital, obtain a name and phone number. Sample history will be the same as the adult. Questions are based on the patient's age and developmental stage of life. And the OPQ or STI is a history of present illness and current symptoms. So question based on the patient's age and developmental stage of life. Our secondary assessment should be performed at the scene unless its patient condition dictates immediate transport if they are critical. So physical examinations will be utilizing a full body scan. Remember, we're doing from toe to head versus head to toe approach. Use a DCAP BTLS mnemonic. Examination focus on certain areas of the region of the body affected. Infants, toddlers, and preschool age should be assessed starting from the feet, so the toe to head, where school age children and adolescents should be a head to toe approach. So the extent of the physical examination will depend on the situation. It could be the head, looking for bruising, swelling, hematoma, substantial blood. Can also be lost between the skull and the scalp of an infant, so more of a head bleed, internal head bleed. A tense or bulging fontanelle in an upright, non-crying infant suggests elevated intracranial pressure caused by meningitis, encephalitis, or intracranial bleeding. A sunken fontanelle suggests dehydration and or hypovolemia. Pupils, note the size, equality, and reactivity to light, so PERLA, P-E-R-L-A. Looking at the nose, so young infants appear to breathe through their nose, and so nasal congestion with mucus can cause respiratory distress. So a gentle bulb or catheter suction of the nostril may bring some relief. Looking for the ears for drainage, for the ear canals, looking for bruising behind the ears with battle signs. The presence of pus may also indicate an ear infection or perforation of the eardrum. In the mouth, we're going to look for, in the trauma patient, look for active bleeding or loose teeth, and note the smell of the breath as well. Examine the trachea for swelling or bruising, and note if the patient cannot move the neck and has a high fever. Remember, if their neck is stiff and they have a high fever, this could be meningitis. Looking at the chest to examine for penetrating injuries, lacerations, bruises, or rashes, the whole DCAP BTLS thing. The patient is injured. Feel the clavicles and ribs for tenderness or any kind of deformities, or areas of bones that can easily be broken. The abdomen, we're going to inspect for a distension, gently palpate and watch for guarding or tension of the abdominal muscles. Note any tenderness or masses and seatbelt abrasions or bruising. With the extremities, we're going to assess for symmetry, make sure everything is the same. So have the patient, they're sitting and their clothes are off or whatever it may be, look from one side to the other, make sure that they match. See if there's any differences. Put each joint through a full range of motion. So this is where you can do the whole Simon Says thing with younger kids. While watching the eyes for signs of pain, unless there's obvious deformity to the extremity. Now, obviously, if you see obvious deformity, don't have them hold their arm over their head, right? So with cap refill in children younger than 6, normal cap refill time should occur within 2 seconds. Remember that cold temperatures make it less reliable. Lack of hydration, we're looking for skin turgor, noting the presence of tenting. In infants, notice if the fontanelles are sunken or flat. Ask the caregiver how many diapers the infant has soiled over the last 24 hours. Determine whether the child has been producing tears when they cry. If they're crying with no tears, they're dehydrated. Determine if oral mucosa is moist or dry, so you can pull back their lips, eyelids, and things like that. Are they dry or not? But more the oral, such as the eyelids, should be more of the lips. So pull the lips down, look at the mucosa, see if it's dry or not. If the child's condition suggests a cardiac etiology, call early for paramedic backup. However, you as a AEMT in New Hampshire have the ability to obtain a 12 lead. As far as vital signs go, some of the guidelines used to assess adult circulatory status have important limitations in pediatric patients. Normal heart rates vary within the age of the child. Versus adults, we look at 60 to 100. Blood pressure usually not assessed in younger children less than 3. If you have the ability to do that, we can take what they call a thigh blood pressure. Those seem to work the best for the infants less than 3 years old. Use appropriately sized equipment. Please do not use adult stuff in pediatrics. It's not going to work. Respiratory rates also may be difficult to interpret. End tidal, if you can get it on the patient, will actually get you a better respiratory rate based upon the exhalation and inhalation. Respiratory rates may also be affected by high fever, anxiety, or pain, or excitement. So note the rates that occur in a child who have begun breathing rapidly with increased work of breathing or for some time and also becoming tired. We got to watch for that muscle fatigue on these kids. And count the respirations for at least 30 seconds and then double that number. And that'll get your respiratory drive over a minute. In infants and children younger than 3 years, evaluate respirations by assessing the rise and fall of the abdomen. And assess the pulse rate by counting for at least 1 minute, noting quality regularity, so rate, rhythm, and quality. And consider taking an apical pulse in infants with small children. So what you can do is you take your stethoscope and go to the apices of the heart, and you can take a listen there, listen for heart sounds, and count the beats that way. Normal vital signs also vary with age, so approach these vital signs should also taking the vitals should also vary as well. So be gentle and talk with the child, and assess respirations, and then the pulse, and then assess blood pressure last. Pupils, you should be utilizing a pen light or the back of your phone light if that's all you have with you. Responsive pupils are a good indication of how well the brain is functioning. And you can also use other appropriate monitoring devices like end tidal, pulse oximetry, cardiac monitoring. So as an advanced EMT in New Hampshire, you have all these different abilities of other assessment tools and techniques that you can use in monitoring devices. Then we get into our reassessment. We're going to just slide one more slide and we'll take a 15-minute break. So reassess the child's condition as the situation dictates. 15 minutes for stable, 5 minutes for unstable, and we continually monitor respiratory effort, skin color and condition, level of consciousness and interactiveness. So keep looking at the patient, keep touching the patient, get them to interact and move. Frequently reassess oxygen saturation and vital signs and repeat the primary survey and adjust your treatment accordingly. Is what we are doing working as we get into our interventions? Always consider getting help from the parent or caregiver. So again, it facilitates the ability to assess and treat. It helps alleviate anxiety for the parent or caregiver. So if you need oxygen by blow-by, they can hold it on. Oxygen by non-rebreather, they can hold it on the child's face. Have them assist you in that part of it. Build a trusting environment and communicate and document everything that you've done. Anything that you did throughout transport, we're going to pass on to the ED personnel. And you may also sometimes administer medications. So in your books, okay, on 38-6, list the medications in your scope of practice at the advanced EMT level for the national registry. Those are the ones you're going to be tested on at your national registry skill stations and your national registry exam. So be familiar with those. And then we have to also know the medications that I've given you guys for the advanced EMT for New Hampshire as well. Okay, that's the scope of practice module on top of what you're allowed to do at the national level. So make sure you pay attention to those as well. All right. Why don't we take 15 minutes? So 35. So we'll come back at 7:50 and then we'll continue on. All right. So I'll see you guys in 15. Everybody good? 15 minutes?
This conference will now be recorded.
So assessment and management of respiratory emergencies. So again, one of the most common things we're going to find with pediatrics is going to be some kind of respiratory distress that goes into respiratory arrest and cardiac arrest. So infants have a limited ability to compensate for respiratory insults. So many infants and children in respiratory conditions have respiratory distress. If the child in respiratory arrest can be resuscitated before cardiac arrest occurs, survival with a return of full function is likely. So when faced with respiratory emergencies, first determine severity of distress, what is going on, and how bad is it. Respiratory distress entails increased work of breathing to maintain oxygenation and or ventilation. So we need to measure, find out what's going on, and administer these life-saving medications, whether oxygen or any kind of sympathomimetic medication to assist. that being albuterol duonebs, things like that for the advanced EMT. Signs of respiratory distress include pallor or mottled color, irritability, anxiety, restlessness, respiratory rate faster than normal for age, so tachypnea, retraction, suprasternal, subcostal, intercostal, abnormal breathing, nasal flaring, inspiratory stridor, grunting, and mild tachycardia. So a patient experiencing respiratory failure can no longer compensate by increased work of breathing. So signs of respiratory failure may indicate decreased or absent retractions. As you can see, signs of impending failure would be mental status, skin color, respiratory rate, respiratory effort, auscultation, blood oxygen saturation, and pulse rate, looking at those changeovers, especially the pulse rate from going from tachycardia to bradycardia, right? That's a significant sign. Now, if a patient's getting better with treatment, you expect that tachycardia to go down to being a normal rate, but if it continues to drop, right, what we're doing is not working. We need to try some different step. We need to call for paramedic level care to assist other medications to help them breathe or intubate to help take over the respiratory drive. Looking for wheezing, stridor, crackles, diminished air movement, severe retractions, tachypnea, switching over to low respiratory drive, agitation, restless confusion, looking at your VPU components of the AVPU scale, central cyanosis in spite of oxygen administration and pallor. Respiratory arrest, we administer immediate BVM, supplemental O2 to prevent progression to cardiopulmonary arrest. Resuscitation of a child from respiratory arrest is often successful, whereas resuscitation of a child in cardiopulmonary arrest may not be, or may be, depending on how bad the situation currently is. So obtain a sample history and allow the child to assume a position of comfort, provide supplemental oxygen. We're going to be allowing the caregiver to deliver the blow-by oxygen to calm the toddler. It may be your best option or best choice, but the child does not show signs of respiratory failure. If they start to show those signs, hey Matt, then we need to start switching over to something different like a BVM or a mask versus blow-by. Electronically monitor the patient's pulse rate, respiratory rate, and oxygen saturation level. Cardiac monitoring, 4-lead end tidal if you can. They'll help you measure the respiratory rate, but also the 4-lead will also measure respiratory rate as well, but it's just not as accurate as it is with end tidal. You also should perform a frequent reassessment to evaluate the effects of your treatments. Cause and effect. What are we doing? Why are we doing it? And what are the effects, the toward effects that we expect to see happen? Right? That's what we're looking for, is what effects are we going to see. So when caring for a child with respiratory emergency, give supplemental oxygen, right? Perform an EKG. If no signs of clinical improvement after treating respiratory distress. So we want to find and kind of rule out potential for any kind of electro or any kind of cardiac involvement, right? So if we see cardiac involvement, that might be a different treatment plan, right? As infants and children can also go into SVT as well. So it's not just an adult thing. They can go in SVT, they can have different arrhythmias. Not as common, but can definitely still happen. So we need to monitor that as well. And if you see it, and it's something that we can't fix, let's say a heart rate of like 220, 230, and the patient's truly an SVT. We don't see a lot of those in the field. It's not very often that we see children in SVT, but again, it can happen. But always go down that respiratory route as well. The airway should also be managed with at least intensive airway. So let's start with us with OPAs, NPAs first. If not, we need to manage with what they call an SGA or supraglottic airway. Those would be like your king tubes, things like that. And then intubation should be performed only if BVM fails. So let's look at our OPAs, NPAs first. Upper airway emergencies. As you can see, foreign body obstructions that you can see here on the screen. So signs and symptoms of decreased or absent breath sounds and stridor. So foreign body aspiration or obstruction. So the child can obviously obstruct their airway with any object that can fit into their mouth. Okay, they're very exploratory. So they like to do things and say, oh, let's put this in my mouth and see what happens, right? And they don't know any better. So in trauma, teeth may have been dislodged into the airway as well. Blood, vomit, or other secretions may also cause airway obstruction. So we need to suction that out and open and maintain that airway. If we have stridor and we think something went down inside and we cannot see it, please do not do a blind finger sweep. Call for paramedic level care. Right? Paramedics have McGill forceps that they can go in and pull stuff out. So if the patient is responsive and coughing forcefully, and you know that for sure there's a foreign body in the airway, encourage the child to continue to cough to clear the airway out. Coughing is a good thing. If the material in the airway does not completely block flow of air, the patient may be able to breathe adequately without any intervention. Do not intervene except to provide supplemental O2. Even as a medic, I'm not just going to start sticking things down the kid's throat. Right? We'll get them to the ER and let them handle it there. But if they go unresponsive, that's when we're going to go in with McGill forceps and a laryngoscope blade to pull it out. All right. So if you don't see it, don't push it. If they're getting oxygenated, and then transport them to the hospital. Allow the patient remain in whatever position is most comfortable and monitor the condition during transport. We do not want to aggravate the current situation. Clear the airway immediately if ineffective cough or no sound, inability to speak or cry, increased respiratory difficulty with stridor, cyanosis, or loss of consciousness. If an infant is responsive with a complete airway obstruction, perform 5 back blows followed by 5 chest thrusts, following AHA recommendations. If a child is older than 1 year and is responsive with a complete airway obstruction, perform the abdominal thrust with the Heimlich maneuver. If there is no suspected spinal injuries and there is no reason to believe an unresponsive child has a foreign body obstruction, open the airway using a head tilt chin lip, look inside and see what you can see. All right, for the obstructed object is visible. Never use a finger sweep if you cannot see an object, then only push it down in further. Chest compressions are recommended to relieve a severe airway obstruction in an unresponsive patient. With the increased pressure in the chest, you create an artificial cough that may force a foreign body out of the airway. So as you're doing chest compressions as part of CPR, if you notice something when you do before you give your breaths, okay, look inside the airway. If you see it, take it out. If you don't see it, right, go back to compressions. All right, anaphylaxis. Right. This is what kills a lot of kids. The anaphylaxis or severe asthma attacks or status asthmaticus. So anaphylaxis is a potentially threatening allergic reaction triggered by an exposure to an antigen somewhere, whether they be crawling on the ground, they pick something up like some kind of dander from a pet, to dust, to whatever it may be on the floors, to touching something, eating something, right? So exposure to the antigen stimulates the release of histamine and other vasoactive chemical mediators from the white blood cells, right? So we have different receptors in the body called H1, H2, H3 receptors that release all this histamine. So we need to give something called that's a histamine blocker, but that's involved in the paramedic level of care, which is Benadryl. But you do carry a sympathomimetic called epinephrine, which will assist with this as well. So onset of symptoms generally occur immediately after exposure, where a child with severe anaphylaxis may be in respiratory failure and shock when you arrive. So the PAT may reveal an anxious child on part of your appearance. So the primary survey will usually reveal hives, or what they call as urticaria, swelling of the lips and oral mucosa, stridor or wheezing, and diminished pulses. Right. Another thing you need to look for is something called angioedema. So what is angioedema? What would angioedema be? Not necessarily swelling of the airway. What specifically about the airway? What specifically about the airway would you see angioedema? The tongue. So significant swelling of the tongue. And that's one of the big indicators as well as for anaphylaxis, because we can't control the swelling of that tongue. We need epinephrine. So sample history may reveal recent contact agent. So the gold standard is epinephrine. What is our dose of epinephrine for a pediatric? What is our pediatric dose for epi? Perfect. All right, so 0.15 milligrams. So diphenhydramine Benadryl is also indicated for an antihistamine effect, that histamine blocker. As of right now, it is not currently at the advanced EMT level. We can see it coming at some point in time, but not currently there yet. But diphenhydramine is still not the gold standard. It definitely helps, but getting epinephrine in is what's going to save the person's life. So he keeps dropping off and coming back. So croup is an infection of the upper airway below the level of the vocal cords. This is what they'll call a parainfluenza virus, which is a pathogen most commonly responsible for croup. The primary effects usually from children 6 months to 3 years of age, with most cases occurring in the fall and winter months. This causes edema and progressive airway obstruction. Now, it's a primarily affects. I've seen 10-year-olds with croup before. It's rare, but I've had a couple patients already that have had croup at 10 years old. Usually it's 6 months to 3 years of age is kind of the primary age group where you're going to see this, right? So what significant sound would you hear for a patient with croup being upper airway?
Wheezing.
Barking cough.
Yeah, the barking cough, the seal bark. You might have, and Sean, you're also not wrong either. You may have some wheezing as well. But the biggest indicator, though, is going to be what Matt O'Connor said, stridor, and that seal bark cough that Jen had mentioned, right? So we're looking for that. Now, you may be called 911 to go to the scene for this, right? And you get on scene and it's gone. Usually, where are they standing when they bring them to you? Outside, exactly. Or in a humidified warm shower where that humidification gets inside. So either that, it can release and open up the airway better with humidity, that steam from the shower, or that cold, which constricts, opening the airway back up again, right? A lot of times these patients can be taken to the hospital by personal vehicle, but if they're bad, right, they require paramedic level care for croup because they're going to get what they call nebulized epinephrine or racemic epi if it's bad. It helps reduce that edema. So stridor is the hallmark sign. The PAT will reveal an alert infant or toddler who has audible stridor and activity or agitation. So be concerned about critical airway obstruction if the child has history of compatible with croup, is sleepy, obtunded, or has significant respiratory distress or cyanosis. Those are the patients that require nebulized epinephrine or racemic epi. Breath sounds will likely be clear over the lung fields all over. You may hear stridor. And I have heard wheezing from time to time, like Sean had mentioned wheezing. It doesn't happen all the time, but I have heard it before, right? But that's not our primary concern, even though there's wheezing there, right? We need to fix that upper airway obstruction, and that's going to be that stridor from the croup. So we got to open that airway back up. So allow for the child to assume a position of comfort and avoid agitating the child. The more pissed off they get, the more agitated they get, the more chance they're going to cause crying and agitation, and swelling will then increase. Humidified oxygen may be beneficial. So if you're a service that actually does have it, great, use it. Call for paramedic backup early if nebulized epinephrine is needed. And in the case of respiratory failure, assist ventilation with BVM will often succeed in overcoming upper airway obstructions. Epiglottitis is very dangerous for a kid. It's a severe inflammation of the epiglottis. So the supraglottic structure is due to the bacterial infection. Now rare in children after introduction of the vaccine against the influenza type B. However, classic presentation of epiglottitis is easily distinguished using a pediatric assessment triangle. The child will look very sick and be anxious. The work of breathing is increased. You'll have pallor and cyanosis will be evident. And the history will reveal a sudden onset of high fever and a sore throat. One other thing you're also going to see with this is excessive drooling. So if you have that, do not suction the airway, do not touch the airway, do not do any procedures that are going to cause the kid to cry. These kids need to get to the hospital as soon as possible. They need to get antibiotics on board. Any kind of agitation with epiglottitis can cause it to swell even more, causing complete airway obstruction. So the goal of the child is to get to the appropriate hospital with a maintainable airway. Ask about immunizations. Make sure that all their immunizations are up to date. And with these symptoms, they do progress rapidly. So look for that that drooling as well as the fever and everything else. So again, do not attempt to look in the mouth. No IV access. Alert personnel at the receiving facility that you have epiglottitis, and be prepared with a BVM in case complete airway obstruction is needed and needed for assisted ventilation. So look for that. Pay close attention. With lower airway emergencies, signs and symptoms should include wheezing or crackles. So the best way is to auscultate lung sounds in a pediatric patient is listen to them on both sides of the chest, front and back, at the level of the armpit, and take a listen. All right, make sure things are silent, get a good set of lung sounds for these patients and find out if there's any kind of wheezing or crackles. So with asthma, it's an acute spasm of the inflammation of the bronchioles in the in the lungs. So associated with excessive mucus production. So we have excessive excessive mucus production, and with that causes inflammation as well, causing that the bronchioles to become more constricted and, like I said, inflamed. So encountered in children with pre-existing history of the disease. So ask. In between attacks, a child is usually asymptomatic until they have the asthma attack. Some triggers would be obviously upper respiratory infections, smoke, changes in environmental temperature, allergies, physical exertion, or emotional distress. So what medications do we carry to assist with an asthma attack at the advanced level? Albuterol and Duodeb. So what classification is albuterol? Okay, I see beta 2. What class is it though? That's the mechanism of action though, is beta 2. It's also a selective, it also has beta 1 as well. So let's talk more about this. And so Justin says sympathomimetic. So that is correct, sympathomimetic. Therefore, it has the mimics of the sympathetic nervous system, which you would expect to see the beta 1, beta 2 effects. So the beta 1 would be what? What's beta 1? What effects would you see with beta 1 effects? What would you see in the system? Increased heart rate, perfect. So it works on rate versus alpha. Alpha works on vasculature. Beta works on rate. If I said beta 2 properties, which Rosa had mentioned, so Rosa, what would beta 2 be then? I think Matt answered it for you. So bronchodilation. Exactly. So that's what we're looking for, is that bronchodilation phase. By bronchodilating allows for more gas exchange, right? So what kind of waveform would we see on capnography for patients that are bronchoconstricted? Not, well, I guess I can give you that. Sawtooth, or what's the other one we can call it? Shark fin. My goodness, you guys are actually learning something. This is great. Awesome. Yeah, so that's shark fin waveform capnography. So as we're getting treatments, we want to continue monitoring that waveform capnography to see if our treatments are working. So reassessing lung sounds. Remember, we're going to see tachycardia already because we're giving a sympathomimetic. But the true thing is looking at that waveform where you're starting to get normal plateaus out of it, the normal waveform for capnography. That's going to be huge. Obviously, let's listen to lung sounds. see if the wheezing is going down. So an acute asthma attack is a hyperactive bronchioles become narrowed and cause reduction in the airflow. So the immune system responds, triggers, release histamines, and then as the attack progresses, expiratory airflow is then further restricted, expiratory airflow. So it's another thing that we can utilize to help with that expiratory airflow at the advanced level. What's something that we have that can provide positive and expiratory pressure to help? What was that?
CPAP.
CPAP, exactly. And Matt got it. Tonder's got it. Awesome. So CPAP. So utilizing CPAP and working with an inline nebulizer, not only are we pushing that medication deep into the bronchioles to allow for better bronchoconstriction, we're also allowing the alveoli to stay open longer to help with gas exchange. So, like I said before, if you're going to provide a procedure to somebody or a medication, you should know exactly what the medication is going to do and what you expect, right? Like we talked about albuterol, I expect to see tachycardia, right? That's part of the thing. I expect for the bronchioles to be opening up. You know, look at the mechanism of action behind the medication you're giving and what you're going to see. I expect to see CPAP opening up the airways better, opening up the alveoli to allow for better gas exchange. I expect to see changes in end tidal, looking from sharp fin to normal waveform. Right? Those are things I expect to see, and why I'm doing something, and what the toward effect is going to be with the medication we administer. So signs and symptoms of an acute airway or acute asthma attack vary from a child sitting up in a preferential position, obvious respiratory distress, prolonged expiratory phases, wheezing if severe, may be heard without a stethoscope. That's what we call the audible wheeze, tachypnea, agitation, tachycardia. Right, these are all signs of an acute asthma attack, and these need to be treated quickly. Right, I've had kids die before because of this. No matter how much you try, they died in the hospital or they died in the back of the ambulance because there's nothing we could have done with all the treatments we've tried, and there's nothing that they can fix it. So administer oxygen by the method most tolerated by the child. So again, if they've been prescribed an MDI containing a beta-2 agonist or other medication, you may assist with the medication or administer a nebulized updraft with a beta-2 agonist, albuterol directed by medical control. It's standing order for you in New Hampshire. Ask if the child's ever been intubated or admitted for intensive care for asthma. That is key to ask. Have you ever been intubated before? If they say yes, then this is going to go bad. So we need to start being aggressive with treatments. Call for a paramedic right away. So we have other medications that we can administer, like dexamethasone and solumedrol as a steroid, and we've also had mag sulfate, and then also have the ability to do intubation as well if needed. Provide pharmacologic agents using beta-2 agonists. Albuterol is most common. Duonebs also have the ipratropium bromide that's in it, which is also a steroid, and also other medications depending on local protocol, like epinephrine. So patients that have significant asthma attacks can also get mag sulfate to help open and smooth muscle relax. They also can go on epi, giving epinephrine 0.3 milligrams like we normally would for anaphylaxis, and also have the ability to do an epi drip as a medic. So call for ALS intervention early for significant asthmatic attacks. Always contact medical control prior to administration of any medication. Okay, that's National Registry. It is not, if you have standing orders, and follow standing orders. If the child is showing signs of respiratory failure, begin BVM 100% oxygen. If needed, you can also administer a BVM through rephrase that again. You can administer albuterol through a BVM with a small volume inline nebulizer. Okay, so you're just pushing it in. There's nothing wrong with doing that. Endotracheal intubation may be necessary, so call early for paramedic backup. Additional treatment, monitoring oxygen saturation levels, end tidal CO2 monitoring, and transport. If the child's condition allows, do not separate the child from the parent or caregiver, as a prolonged unrelieved asthma attack may progress to status asthmaticus, where there's minimum air movement. It says this is a dire emergency and treatment is more aggressive, must be performed en route to the hospital. Right, they're going to be getting a lot of things done, IV therapy, IV medications, get the paramedic on board sooner than later. Other symptoms would be hypoxia, acidosis, which we can measure with end tidal, hypoxia measured with pulse oximetry, respiratory failure, and physical exhaustion. They get so tired they can't breathe anymore. Right, so requires assisted ventilations or advanced airway management. Advanced airway management being, unless they go into cardiac arrest, you're not going to use a supraglottic airway, but that would be more of a paramedic coming in intubating while they're still breathing but unconscious. Any questions on asthma at all? No? Okay. I'm sure I hit all the high points for you guys on that. Pneumonia is a common disease that affects the lower airway and lungs. This is going to be our lung disease that will cause more of the crackles and fevers and things like that. We'll talk more about that here in a moment. So this can occur at any age, commonly seen in infants, toddlers, and preschoolers aged 1 to 5, usually caused by a virus, more of a viral pneumonia. As children get older, the incidence of bacterial pneumonia definitely starts to increase at that point. It starts off as viral. As they get older, they get bacterial pneumonia. It's a recent history of a cough or cold or lower airway infection, and it can also be caused by direct lung injuries as well. So presentation for pneumonia would be usually rapid breathing or breathing with grunting or wheezing sounds, nasal flaring, tachypnea, crackles, hypothermia, or fever, depending on which way it's going to go, and unilateral diminished breath sounds. So observe for signs of accessory muscle usage, and infants may also not tolerate pneumonia as well as older children or adults. Right? If there's wheezing, even though it's not asthma, we're still going to go with bronchodilators for these patients as well. Treatment is supportive. Monitor the patient, administer oxygen, administer bronchodilators. If you hear wheezing, vascular access is generally not indicated, but if conditions warrant medication therapy, IV or IO access en route to the hospital. Diagnosis is confirmed with a chest x-ray, followed by antibiotics and primary treatment. We do a chest x-ray and they'll look for the whiteout in the lungs, and that will usually indicate where the pneumonia is located. Bronchiolitis is a viral infection. It results in inflammation and constriction of the bronchioles, often caused by RSV. This occurs within the first 2 years of life and is more common in males and widespread in the winter and early spring. We've actually seen an uptake in RSV, and I think I'm talking to people in the ERs that they are seeing a lot more RSV cases now. What does RSV stand for? What does RSV stand for? Anybody? Any thoughts?
Respiratory syncytial virus.
Perfect. All right. So bronchioles become inflamed, swell, and fill with mucus, so the airway in the infants and young children can become easily blocked. So look for signs of dehydration, and shortness of breath and fever may also be present. Right. So treatment for this is using a calm demeanor and allow for position of comfort. We're going to treat the airway and breathing problems as appropriate. If you have humidified oxygen, it's very helpful if you have it available, so utilize it. Be prepared to assist ventilations and call for paramedic backup for advanced airway management. With bronchiolitis, there's not much we're really going to do unless they need to be intubated in the field. There's not a lot of stuff that you're going to do at the paramedic level for this. You need antibiotics. Pertussis or whooping cough is a potentially deadly disease caused by a bacterium that is spread through the respiratory droplets. As a result of vaccinations, it is less common in the US, but I've seen a lot of people that are not getting their kids vaccinated. So again, if they don't have pertussis shots or vaccines, whooping cough is a potential. Signs and symptoms similar to the common cold, but coughing, sneezing, and a runny nose. So this is a disease, as the disease progresses, the coughing becomes more severe and is characterized by a distinctive whoop sound heard during the inspiratory phase. So keep the patient, keep the airway patent and transport. Because it's contagious, follow standard precautions, including mask and eye protection. As far as general assessment and management of the respiratory emergencies go, As you can see in the picture here, they're utilizing a Broslow tape, which is very, very helpful. So airway adjuncts used to maintain a patent airway in children in adequate ventilations, and then choosing the appropriate size equipment. And if adjuncts are not the correct size, it may cause more harm than good. So what I would highly recommend, and I say recommend, I cannot force you to do so, but download the app PDStat, PEDISTAT, and that will be very helpful for you in, I can't type it out right now, but well, let me click on the chat box for some reason. But PDStat is the name of the app. It's like, I don't know, it's like $5 or $10. It's not much. It's very, very helpful when utilizing for pediatric assessment and medication administration, including fluids as well, which is something that you'll be doing. So take a look at the app, download if you can. Very helpful. Oropharyngeal airways are used for patients who are unresponsive and respiratory failure. Remember, they should not have a gag reflex, and should be used on children who have ingested should not be used on children who have ingested a caustic or petroleum-based product. So avoid also injuring the hard palate as well. So if you need to learn how to put in a oropharyngeal airway, Skill Drill 36-2 has that in your books. The nasal airway is used for a responsive pediatric patient with respiratory failure, rarely used in infants less than 1 year, and should not be used in patients with nasal obstruction, facial trauma, or moderate to severe head trauma. 36-3 teaches you how to put them in, which you should already know, being EMTs already. And if inserting the airway in the left side, insert the tip into the left nares upside down, with bevel pointing toward the septum. Then reassess the airway after insertion. For oxygen delivery, all ill or injured infants and children should receive supplemental oxygen, and the method will be determined by the adequacy of the patient's breathing and tower tidal volume. So a lot of this stuff we're going to be covering here is BLS review. It's all basic level stuff. Just kind of getting a little more in depth on the A&P behind it, and more about the cause and effect of what we do. So deliveries and techniques used blow-by oxygen is usually 6 liters a minute. Nasal cannula 1 to 6, on a breather 10 to 15, and a back valve mask from 15 liters a minute. But here comes the important part, and let's talk about drugs for a minute. As far as we know how many liters per minute to administer, but what is the percentage of oxygen based upon nasal cannula, non-rebreather, and back valve mask? So who can tell me those really quick? What is the percentage range for a nasal cannula? How much oxygen based on percentage is being administered between 1 to 6 liters per minute? Okay. Any other guesses?
Is it like 56%?
Okay, it's lower than that, and Tondra, it's a little bit higher than what you've mentioned. Yeah, so 30% is in the range. So 22 to 44%. Again, these are things you will be tested on in your national exam, is percentage of oxygen that you administer. So a nasal cannula runs between 22 to 44% oxygen as you administer. What about a non-rebreather? Obviously, it's going to be higher than our nasal cannula. Okay, a lot of good guesses. So 80 to 90%. 80 to 90% oxygen for a non-rebreather. And then your back valve mask is with an oxygen reservoir, 100. Right? Perfect. So get to know those numbers, 22 to 44, 80 to 90, and then 100%. It'll be very important to understand when you're administering the cause and effect behind it. And if you ever work on a transfer truck with a paramedic and they start talking about ventilator calls, so I know some people in the group have been on them before, whether with me or another medic. We talk about FiO2 percentage, and the FiO2 percentage is a fraction of inspired oxygen, and that's the numbers we're talking about now. What ranges are we going to put them at? So it's all important information. With CPAP, however, There are some CPAP devices that are out there that have the ability for the AEMT to adjust oxygen percentage that goes in on top of the PEEP. So there are some devices that are there. So be familiar with the devices you have in your service, whether or not you can deliver a different percentage of oxygen. So the use of non-breathing masks or blow-by techniques is indicated for patients who have adequate respiratory rates and tidal volumes. So blow-by oxygen does not deliver high concentrations of oxygen. It's lower numbers. All right, so looking at about from 15 to 22%, depending on how close it is to the mouth. So for this to work, we want to make sure place an oxygen tube through a small hole in the bottom of an 8-ounce cup. If you don't have that, then you can actually hold it in front of their face. But as you can see in the photo here, if you have cups in the ambulance, you can do that. If not, then we got to have the mom hold it close enough to the face to be able to get that in. We're going to hold the cup approximately 1 to 2 inches away from the child's nose and mouth, or a nasal cannula if patients prefer that. And if they are going to be using a nasal cannula, then use end tidal with it too. Remember, then you can deliver your 22 to 44% oxygen. So a non-rebreather can deliver up to 95%. The average number is between 80 and 90% oxygen, and the back valve mask being 100%. So I'm pretty sure we all know how to administer non-rebreather nasal cannulas and BVM. So I don't think I need to go in depth on these for you guys. There's nothing different. If you have any questions, you look at skill drill 36-4 in your books. To rescue or BVM device ventilation is probably the best you can use. So one person can hold it down. This requires two, it says 2 advanced EMTs, 2 providers can utilize this as well. So one can hold it down in the face using double EC clamp while the other one ventilates. Right, so there's different options that are there. All right, so management of CPR. Right, cardiopulmonary arrest most often associated with respiratory arrest or failure prior to, where the child becomes hypoxic and the heart rate slows down. Remember the bradycardia, becoming more bradycardic to the point where they drop below 60. Next thing you know, they're in cardiac arrest. The overall survival rate from cardiac arrest in pre-hospital setting in children is low. Okay, versus adults, we have a higher chance of getting it. With children, it's low because they've depleted so much oxygen out of their system, which is why we got to catch them before they go into respiratory failure. Many of those who do survive, though, have permanent brain damage as a result of the arrest. So ventilate with high concentration oxygen early to try to avoid the development of cardiac arrest. So this develops, so shock develops when the circulatory system is unable to deliver sufficient amount of blood to the body. This can result in pediatric cardiac arrest. Early recognition and prompt intervention can prevent permanent disability or death. So what is our dosaging again? How many mLs per kilo? For pediatrics, what's our number?
10.
20 mLs
Sorry,
per
20.
kilo. Yeah, that's okay. Yeah, you got the neonate one. 20 mLs per kilogram. So know these numbers. These are very important so we don't flood a patient. So remember that children can compensate for shock. So early recognition and prompt intervention can prevent permanent disability or death. So remember, they compensate until they actually drop off. Hypotension occurs very quickly and is unpredictable. You don't know when it's going to happen. It may result in rapid deterioration to cardiopulmonary arrest. So catch it early. Look for the tachycardia, tachypnea. You're not going to have those blood pressure changes right off the bat. So look for them. Common causes obviously would be hypovolemia, sepsis, allergic reactions, and poisonings. So shock from a primary cardiac event is rare. So greater than 25% blood volume loss significantly increases the risk for shock. It does not take much for a pediatric to lose enough blood to put him in a shock-like state. So tachycardia, poor capillary refill time greater than 2 seconds, and mental status changes are signs of shock in a pediatric. So before treating the patients, by assessing ABCDEs, intervening immediately is required. Remember CABDE if you have cardiac arrest. In assessing circulation, pay particular attention to the following. The pulse, anything over 160 beats per minute suggests shock. All right, skin signs, looking for that pale color as well. Cap refill of greater than 2 seconds. The color as well. Changes in pulse rates, color, and skin signs and capillary refill time are all important clues suggesting a patient's in shock. Remember, if you catch it and compensate it, we start giving some fluid to help with this, we're ahead of the game. It's when you get the late signs and late recognition. Blood pressure may be difficult to measure. The cuff size must be proper size, so two-thirds the length of the upper arm. The value of the normal blood pressure is age specific. So remember, this may be normal with compensated shock, but low blood pressure is a sign of decompensated shock. So you see hypotension, we're on the decompensated shock phase, getting closer to irreversible. So you got to catch it early. Determine when the signs and symptoms are first appeared and whether any of the following have occurred. Decrease in urine output. So you got to ask how many wet diapers they've had. Absence of tears, even when the child is crying. Sunken or depressed fontanelle. And changes the level of consciousness and behavior. So time should not be wasted performing field procedures. Get them in the back of the ambulance and start working. And limit management to ensure the airway is patent. Ensure that text from one of the students. So ensure that the airway is patent and open. Control bleeding. Oxygen is needed. Give supplemental oxygen to help with that low oxygen reserve. Continue to monitor the airway and breathing. Position the patient in a position of comfort as dictated by local protocol. Keep the patient warm. And unless absolutely critical, perform this time-consuming procedure en route. Anaphylactic shock anaphylaxis, remember, is a major allergic reaction that involves a generalized multi-system response to an antigen foreign substance. The cause can be like insect stings, medications, or foods. So signs and symptoms would be hypoperfusion, stridor, wheezing, increased work of breathing, altered appearance, restlessness, agitation, and sometimes a sense of impending doom. And then highs are usually present, or another name for it would be urticaria. So treatment is oxygen, positioning of the patient for oxygen delivery, and keeping the patient calm. Based on protocol, you can assist with epi auto injector. At your level as an AEMT, you can draw it up through an ampule. Administer epi subcutaneously or via auto injector. Intramuscular is how we're going to be doing it in our protocols. In the lateral thigh. IVIO access and 20 mL per kilo of isotonic crystalloid solution to maintain perfusion. Right, so normal saline and paramedic backup, they administer different medications as needed. If they have any bleeding disorders like hemophilia, which is a congenital condition in which the patient lacks one or more clotting factors of blood, this is usually hereditary and found predominantly in males. So all injuries are potentially serious. We want to transport immediately and do not delay tourniquet application for life-threatening hemorrhage. Intravenous access, IV therapy is not performed frequently in children, so techniques, indications, and contraindications are still the same as adults. The same IV solutions and equipment can be used. So looking at different catheters we have here, please do not put a 14 gauge catheter in a pediatric. Okay, for one, you're going to blow the vein, and two, it's just not right. Don't do it. So we start at the top. Yellow is 20, yellow is 24, blue is 22, pink is 20 gauge, green is 18, gray is 16, orange is 14 gauge. The best for insertion for pediatrics, okay, we do not have 26s. We do not have 26 gauge catheters for insertion, right? We only have 24 and bigger, right? Please do not go higher than a 20 in a pediatric, okay? Usually a lot of the infants, we're using 24 gauge catheters. So butterfly catheters are useful as well, but we do not carry butterfly catheters in the ambulance. They can be placed in the same location as an over-the-needle catheter and a visible scalp vein as well in infants. And remember that they have a higher rate of infiltration as well. So with butterfly catheters, so that's why we don't do them. As far as administration or fluid sets, fluid is very important. So use a special type of micro drip called a Votrol or Buterol set. You can also use a micro drip set, a 60 drop as well. But the best way to do it, honestly, is draw it up in a syringe and administer that way for boluses. These are different IV locations: the leg, the foot, the top of the wrist. Those work pretty well. It's hard to find ACs, but if you have one, utilize it. Those are different locations you can utilize. Sometimes the best choice is an antecubital vein if you have it. But if you can't find an AC vein, then don't go for it. Don't just blind stick. A lot of times, though, honestly, the top of the wrist is really good, or the feet. Interosseous access, obviously a pediatric, adult, and large adult from pink to yellow. We've already covered interosseous access quite a bit already. We'll do more on Sunday, so we'll kind of get through this pretty quickly here. All right, so potential complications obviously would be compartment syndrome if you fail, or if you push too much fluid and there's a leak. Failed insertion, obviously growth plate injury, osteomyelitis, skin infection, and bony fractures as well. Fluid resuscitation, the appropriate fluid resuscitation is crucial for these patients. Not only is it crucial, but not to give too much. So you have to measure what you're giving, right? Overload can result causing pulmonary edema and cardiac failure. So if volume is insufficient, it will not be effective in treating the child's condition. So fluid resuscitation for hypovolemic shock begins with an initial bolus of 20 mL per kilo of an isotonic crystalline solution, followed by careful reassessment. That's why I said the best way to do this is pulling it up with a 3-way stopcock and a bag of fluid, then administering it through a syringe as a bolus will be your best method. So we're going to go through these 14 slides here. We'll take a 10-minute break, and then we will finish up. So assessment and management of neurologic emergencies, altered mental status. We look at several common causes: hypoglycemia, hypoxia, seizure, or drug and alcohol ingestion. So assessment and management of neurological emergencies may exhibit in many different ways for altered mental status: lack of response to verbal commands and pain, combative behavior, confusion, thrashing out, drifted in and out of an altered state, change in pitch and nature of a cry, right? So we want to use the old mnemonic AEIOU tips to reflect any major causes of altered mental status. Some signs and symptoms will vary from simple confusion to coma. So management focuses on ABCs and transport. If the level of consciousness is low, the child may not be able to protect his own airway. If they can't protect their own airway, we may have to put something else in to protect that, whether it be an NPA. So ensure the patient has a patent and adequate breathing and transport to the hospital. Some common causes of seizures would be child abuse, electrolyte imbalance, fever, hypoglycemia, infection, ingestion, hypoxia, medications, poisoning, seizure disorder, recreational drug use, head trauma, or any kind of idiopathic type deal. So many, so they also may manifest in a variety of different ways depending on the age of the child as well. So febrile seizures. What can cause that? What causes a febrile seizure?
Fever.
Okay, so Justin got high temp and Matt said a rapid rise. So it is a fever, Ken, you're right. So it's that rapid rise though. So if you have a temp of like 100 and it goes to like 104 over a very quick period of time, can cause that febrile seizure. And that's the body's mechanism of trying to drop that temperature back down. So a lot of times you'll be called for seizure-like activity. And then you're gonna get to the scene and be like, oh, the fever's like 100. Well, it's probably like 104 prior to that, and that seizure caused that temp to drop, right? So you got to keep that in mind as well when you're doing your assessments. What was the temp prior to? And how do we take a temperature in an infant? Yeah, rectal. That's the only way we're going to be able to do it. So in older children, seizures are more obvious and typically consist of repetitive muscle contractions and unresponsiveness. We're looking for that tonic-clonic movement, that shaking and jerking movement. So once the seizure stops, the patient's muscles relax and breathing becomes more labored. This is the postictal state. So the longer and more intense the seizures are, the longer the postictal unresponsiveness and confusion will last. So once the pediatric patient regains normal level of responsiveness, the postictal state is now over. Please make sure you check a blood sugar because that could have caused it as well, right? Remember, shaking and muscle twitching and muscle usage can also drop blood sugars as well, especially in kids. Seizures that continue every few minutes without regaining responsiveness or last longer than 30 minutes are referred to as status epilepticus, and recurring or prolonged seizures should be considered potentially life-threatening. As far as management goes, securing and protecting the patient's airway, position the head, open the airway, clear the mouth, provide 100% oxygen to these patients as well, and tip them and turn them into the recovery position on their left side. So we already talked about febrile seizures. So most pediatric seizures result from a fever alone, but typically occur within the first day of a febrile illness, characterized by generalized tonic-clonic seizure activity lasting less than 15 minutes with short or no postictal state. This may be a sign of more serious problem, such as meningitis. So what caused the seizure? This is determined if the patient has a history of past febrile seizures as well. So getting that good sample history and finding out more of the history of the child is going to be key in these assessments. So management, obviously ABCDEs, cooling measures with tepid water, right? So cooler cloths, cooling the patient down. Prompt transport. For patients that have had a seizure, establish IV or IO access and obtain a blood glucose reading. And if the patient's hypoglycemic, give glucose. With meningitis, obviously there's an inflammation of the meninges caused by an infection by bacteria, viral, fungi, or parasites. And if left untreated, it can lead to permanent brain damage or death. Right. So we look at the greater risk would be in males, newborn infants, geriatric patients, prior history of meningitis for those who live in crowded conditions, children who have not received proper immunizations, those with compromised immune systems, history of head trauma or brain surgeries, or those with shunts, pins, or other foreign bodies within the brain or spinal cord. Remember, if we have this meningitis, we look for the fever as well. The fever, stiff neck, altered level of consciousness are very common in all ages. So infants younger than 2 to 3 months can also have apnea, cyanosis fever, and a distinct high-pitched cry or hypothermia. The meningeal irritation or meningeal signs would be bending of the neck forward or backward, causing a great deal of pain. They call that nuchal rigidity. So what you want to do is you want to have the patient touch their chin to their chest, then go back and hyperextend. Towards hyperextension, don't actually hyperextend the neck if they have significant pain. Patient also refuse to move the neck with the legs or curl into a C position as well. So once a sign of meningitis in the infant is increased irritability and bulging fontanelles without crying. So you'll be able to feel that as well. So don't push on it, but just kind of feel over it. If it's bulging out, it could be potential for meningitis as well. So Neisseria meningitis causes a rapid onset of meningitis symptoms, often leading to shock and death. So children have a small pinpoint cherry red spots or a larger purple or black rash on the face or body, as you can see here, looking through their legs. All patients with possible meningitis should be considered highly contagious and infectious for anybody, not just for the children, even for adults. Use standard precautions, follow up at the hospital, and learn the patient's final diagnosis as well. Have them test it. We need to find out what it is. If exposed to saliva or respiratory secretions, you should receive antibiotics as well. You should receive them. as a provider. In treatment will be supplemental oxygen, assist with ventilations as necessary, reassess vital signs frequently, and if vitals are unstable, vascular access and administer IV fluids. So any questions at all with neurological? No, we're all doing pretty good. I know this is a long lecture, so I do apologize. A lot to cover with pediatrics. So why don't we take 10 minutes, we'll come back at 9 o'clock, and then we'll finish up the rest of the chapter. We'll see you guys at 9.
This conference will now be recorded.
All right, so assessment and management of gastrointestinal emergencies. So signs and symptoms of this may also be very vague. So patients are really not able to pinpoint the exact site where the pain or discomfort originates. With pediatrics, they say my belly hurts. Okay, well, where does it hurt? That's when we have to start touching and palpating and seeing exactly where things may actually be. Remember that everything is more compressed in a pediatric as well, so keep that in mind. So a large amount of bleeding may occur within the abdominal cavity without any outward signs of shock. Liver and splenic injuries are very common and may also lead to a life-threatening emergency. So monitor for signs and symptoms of shock as we look for tachypnea, tachycardia, those things we talked about. And we're not going to see that hypotension yet. And a common source of gastrointestinal upset is the ingestion of certain foods. They may start getting like maybe a gastroenteritis type deal or some kind of inflammation in the gastrointestinal tract. So in most cases, the pediatric patient will be experiencing abdominal discomfort with nausea, vomiting, and or diarrhea. Now the problem with the nausea, vomiting, diarrhea, right? So the big problem with nausea, vomiting, diarrhea is that we can have significant fluid loss. So we have to ask the question of how much diarrhea have they had, how many times have they gone in their diaper, how many times have they vomited in the last couple hours, to see if we have that decrease in fluid causing that hypovolemia or the dehydration of the patient. So we have to ask these questions, right? Because the signs and symptoms may be very vague, so questioning is very important. Appendicitis, if untreated, can lead to a peritonitis or shock, so increased fluid of the peritoneum, causing inflammation and infection or shock to the patient. This goes, same thing with adults, to kids. This presents with a fever and pain on palpation of the right lower abdominal quadrant. Rebound tenderness is a very common sign. We're going to transport for further evaluation. So what is the point called again? Jen, you must know this one here. We just talked about it. What point are we looking for? Yeah, so literally Jen and I were having this discussion yesterday, but McBurney's point is where our location or our palpation is going to be located for acute appendicitis. All right, so obtained through history from the patient or primary caregiver. How many wet diapers has the child had today? Is your child tolerating liquids, and is the child able to keep them down? How many times has your child had diarrhea, and for how long? And are tears present when your child cries? These are assessment techniques and findings we need to know to find out if the patient is hypovolemic or dehydrated. So assessment and management of the toxicologic emergencies, right? Which we will be covering under one of our makeup days. I did not forget that we have 2 chapters we still need to go over. The poisoning is very common among children. They can occur by ingesting, inhaling, injecting, or absorbing a toxic substance. So common sources of poisoning will be alcohol, aspirin, acetaminophen, household cleaning products, houseplants, iron, prescription medications, illicit drugs, and vitamins. So signs and symptoms of poisoning may vary widely depending on the substance and the age and the weight of the child. Everything is done through weight base. Okay, so toxicology is very important to have the understanding of how that works and what to look for. and we put things into a series of signs and symptoms, and those would be called toxidromes, right? So we look at cholinergics, anticholinergics, opiates, things like that, all these different types of series of signs and symptoms that indicate a specific type of overdose or a type of toxin or poison. Organophosphate being another one. So all different ones that are out there they can get in touch with. So the patient may appear normal at first, but may be confused, sleepy, or unresponsive. So this may result from being fed harmful substances or child abuse. So this may also be exposed to drug or poisonings left on the floors, pills that may have fallen down, or kids that can access pill bottles. They can also be illicit drugs that are smoked as well. They may be curious and then ingest poisons they find at home or in the garage as well. So they just walk around, like antifreeze being one of them. It's green, tastes sweet. They may actually drink it, but very, very harmful. So after you've completed a primary survey and address immediate life threats, ask the following. What is the substance or substances involved? Approximately how much of the substance was ingested or involved in the exposure? What time did the incident occur, and has the child vomited? How much does the child weigh? Are there any changes in behavior or level of consciousness? And was there any choking or coughing after the exposure? First, perform an external decontamination. Remove any tablets or fragments from the patient's mouth. Wash or brush the poison away from the skin, right? Please do not just start washing chemicals. Make sure that it's not water-reactive chemicals. ABCs. If the child demonstrates signs and symptoms of shock, position the child supine, keep the child warm, and transport promptly. Remember, if it's shock-like symptoms, what are we going to do? Cardiac monitoring, IV therapy, fluids. In some cases, give activated charcoal if approved by medical control or local protocol, right? Usually it's 0.5 to 1 gram per kilogram of activated charcoal. That's going to be your dosing, 0.5 to 1 grams of activated charcoal per kilogram of body weight. You're going to see this again. Not recommended for patients who have decreased level of consciousness and cannot protect their own airway or who are unable to swallow. A lot of the activated charcoal now is being given with sorbitol in it. Sorbitol is going to make you have diarrhea versus vomiting. So dehydration and fluid loss are greater than fluid intake. This is where we start causing our dehydration emergencies. So vomiting and diarrhea are the most common causes. If untreated, can lead to shock and death, which is why we need to give our fluid boluses at 20 mLs per kilo and get IV access. This can be mild, moderate, or severe, and young children can also compensate by decreasing blood flow to the extremities and directing to the vital organs. So they're compensating to the point where we cannot see certain changes in vital signs, which is why it's so important to monitor heart rate. Getting them on a 4-lead cardiac monitor and monitoring their respiratory drive as well. And if you can get end-tidal, that's a very good way of monitoring respiratory rate with that. You can also check for skin turgor as well. As you can see, I'm pulling back here, looking for that skin tenting and movement. So ABCs, transport, its signs are moderate to severe. Look at ABCs and vitals. As far as fever goes, temperatures of greater than 100.4 or higher are considered abnormal. These are rarely life-threatening, but understand that it's not just a fever. You have to look for the common causes of that fever, and that can become life-threatening, like infection, status epilepticus, cancer, aspirin drug ingestion, collagen vascular disease, including arthritis or systemic lupus as well. High environmental temperatures, hyperthermia as an increase in body temperature causes an inability for the body to cool itself, right? Typically seen in more warmer environments. So an accurate body temperature is important. A rectal temp is most accurate for infants and toddlers. Older children will be able to follow direction for the thermometer placed under the tongue or arm, under the arm being axillary or oral temp, right? These skin readers and these infrared, those are absolutely junk. They're horrible. They shouldn't even be used. They're not accurate at all. I've had patients before that we've used infrared before that, and they've had temps of like 98 degrees, and then you take a rectal temp, they're like 104. So to me, they're not accurate. Tympanic temperatures are more accurate than skin readers. So again, make sure you have the appropriate devices to be able to take temp. Other signs and symptoms of a fever can have different causes: respiratory distress, shock, stiff neck, rash, skin hot to the touch, flushed cheeks, seizures, sensitivity to light, or bulging fontanelle in infants. Remember, all these mean something a little bit different, right? Stiff neck, bulging fontanelles, intracranial pressure, seizures, the stiff neck being meningitis, skin hot to the touch, rashes, urticaria as well, any kind of infection, anaphylaxis, some things that are an kind of allergic reaction as well. All these things can cause increased temperature. So assess for other signs and symptoms such as nausea, vomiting, diarrhea, or decreased feedings and headaches. Okay, don't look just for those specific causes, but also look for other signs and symptoms and other causes it potentially could be. Provide immediate transport and manage the patient's ABCs unless associated with shock or severe dehydration. IV therapy is generally not necessary, but if you have shock or severe dehydration, you need to get a line. Keep in mind that vascular access is going to be tough because they're already vasoconstricted from that. So assessment and management of hypoglycemic emergencies, abnormally low blood glucose levels. So infants and children have limited stores of glucose, which obviously can quickly be depleted due to an illness, injury, or stress. So life-threatening emergencies that require immediate treatment, if unrecognized or treatment is delayed, permanent brain damage or death can result. Remember, sugar, oxygen, blood. 3 things we have to stay alive. Don't forget those. So signs and symptoms would be hunger, malaise, tachycardia, tachypnea, diaphoresis, and tremors. Severity depends on how low the blood glucose levels have dropped. So obtain a blood glucose reading in a child you suspect is hypoglycemic. In children with a known history of diabetes, ask, have you ever taken insulin? Have you taken your insulin today? If so, what was the dose? Has your medication recently changed? When was the last time you ate? And what did you eat? Have you been playing outside or otherwise exerting yourself, causing more energy to be expelled before dropping a blood sugar? We want to make sure we administer oxygen 100%. Assist ventilations as needed. Monitor vital signs closely. If the child is responsive and alert enough to swallow, administer oral glucose as well, following protocols. If the child is also mental status or incapable of swallowing or administering IV glucose, administer IV glucose. For ages 1 year and older, administer 0.51 grams per kilogram of D25 via IV IO push. Right? That's going to be your dose for your National Registry exam. It's 0.5 to 1 grams per kilogram of D25. Right? Not D50, not D10, but D25 via slow IV IO push. For infants and neonates, administer 200 to 500 milligrams per kilogram of IV IO push. D10 may be given in place of D25 if it is within your scope. So now to mention New Hampshire, we carry D10, not D25. So D10 is going to be your administration. If an IV cannot be established, insert an IO needle. If an IV or IO vascular access is not available, medical control may order the administration of 1 milligram of glucagon by intramuscular injection. So repeat the blood glucose reading 10 to 15 minutes following administration of glucose. If the patient is still symptomatic and the blood glucose reading remains below 80 milligrams per deciliter, repeat the glucose as needed. We don't want to have to go to the glucagon route. We want to be able to give that D10 first, okay? You have to have glucose stores to be released for glucagon to work, right? So again, if you can't get access, then go to your glucagon administration. But if anything, try to get your IV access first for administer of dextrose. The problem with dextrose is that it's very necrotic, right? So if you have an IV site, make sure it's very patent. If it's not, and it leaks into the skin, it'll cause tissue necrosis. Okay, so remember your dosing: 0.5 to 1 gram per kilogram of D25 or D10, or 1 milligram glucagon intramuscular injection. And that can be given in adulthood. That's perfectly fine. Hyperglycemia can either be presented with a problem with a new onset diabetes mellitus, or may have a complication in a child with a known history of diabetes. If not recognized promptly or promptly treated, it can result in severe dehydration or DKA. What is DKA again?
Diabetic ketoacidosis.
Yep. And what kind of smell would you have on their breath? Fruity smell caused by what Matt O'Connor said, ketones. So the ketone release causing that fruity smell in the breath. Remember that antifreeze also has a sweet smell to it as well. So if you have a child that ingests antifreeze or something else with a sweet smell, all right, still check out blood sugar anyways, but just don't keep in mind if it's normal and they have that sweet smell, it could be something else they ingested. So just, again, don't forget about toxidromes as well in toxicology. Typically, we find that the dose of insulin was missed, or a greater proportion of food was eaten compared to with the dose of insulin, or the insulin pump maybe have malfunctioned. So signs and symptoms depend on the level of blood glucose, really. So ask the same questions would you would suspect you would for suspected hypoglycemic patients. So ask them the same questioning as you go through it. As far as hyperglycemic patients, 100% oxygen, IV access, you're going to administer a 20 ml per kilo bolus of normal saline or LR, a solution as needed. Children with hyperglycemia or DKA are often severely dehydrated. So we can go with LR for these specific patients for the pediatric. For adults, LR is the way to go. For pediatrics, though, we want to be careful how much electrolyte we're giving, but because we're hyperglycemic and dehydrated, we suspect that they already have decreased electrolytes as it is. So closely monitor the patient's ABCs. Immediate transport. If you can't get an IV, insert an IL if the patients are critical. If the patient respiratory status deteriorates, call for paramedic backup so we can help assist airway managements. All right, so as far as drownings go, drowning is the #1 cause of unintentional death among children ages 1 to 4 in the U.S. The children often fall in the swimming pools and lakes, but many drown in bathtubs and even buckets of water. Alcohol is a frequent factor among adolescents with this. So keeping this in mind, okay, children like to explore, and they do not have the sense of danger when it comes to drowning. And usually what's happening with this is that they have a lack or lapse from adult supervision and that layers of protection to protect the kid from getting into certain pools or what it may be. I go more in depth in this in my water rescue classes that I teach. So if you're interested in learning more, take the awareness class if you don't want to go into the water. You can learn a lot of stuff about this. So the principal cause of an injury that results from drowning is lack of oxygen. So immersion in icy water can also cause hypothermia. So diving into water also increases the risk of neck and spinal cord injuries for the adolescents diving. Right, so there's different potentials that are all there. So signs and symptoms of a submersion injury or length of submersion would be coughing, choking, airway obstruction, difficulty breathing, altered mental status, seizure activity, unresponsive, fast, slow, or no pulse, pale cyanotic skin, or abdominal distension. So this being taking a lot of water into the lungs could cause abdominal distension, cyanosis, the pale cyanotic skin, lack of oxygen, could be caused from a laryngeal spasm. The fast, slow, or no pulse is what they call mammalian diving reflex, where the body shuts down and goes into a bradycardic or no pulse event. We need to warm the patient back up again. Obviously, seizure activity, head trauma, lack of oxygen, hypoxia, altered mental status as well. Other things that could cause this would be like shallow water blackout or hyperventilation, purposely hyperventilating, causing the patient to have a shallow water blackout, go underwater, and then take in water that way. So there's a lot of different methods of drowning that are out. There will be dry, wet drowning, million diver reflex, to shallow water blackout, to all the other different ones that are there. So keep that kind of stuff in mind. Or secondary drownings, or they call the dry drownings, that happen, hours later at home. It's very rare, about 10%, but still they do exist. And I've had 3 or 4 of them probably within the last 10 years where I've had dry drownings or secondary drownings later on. So management, obviously ABCs, rescuing a patient from the water, make sure you're safe. Contact paramedic crew to intervene as needed. Drowning patients, golden standard for airway management is intubation. However, with the adolescents, when they're old enough to be treated like an adult, we can also utilize CPAP as well to help push some of the fluids out. Be prepared to apply suction, cervical collar of trauma, pad all spaces before under the patient before securing to the backboard, CPR on the unresponsive. All right, so getting close to the end here, probably another 30 slides to go or so. So pediatric trauma and emergencies management. So remember, trauma is the #1 cause of death of children in the United States. So infants and toddlers are most commonly hurt as a result of unintentional suffocation, drowning, falls, or abuse. Motor vehicle crashes, including those involving bicycles and pedestrians, are the most significant threat to the well-being of children's ages 5 years and older. Remember, with motor vehicle accidents, children turn towards it versus adults that turn away. So we suspect to see more frontal injuries and back injuries for infants, or I should say infants, but for children. Other common causes of traumatic injury and death include falls, gunshot wounds, blunt injuries, and sports activities. Remember that there are psychological differences, so children less mature psychologically than adults. Children are also injured because of underdeveloped judgment and lack of experience. That's how they learn, so they potentially could become injured. Some physical differences, obviously location of injuries may differ from that of an adult from the same type of accident. We just discussed that in a couple of slides ago when we talked about how they turn and aim towards the vehicle. So the force of injury also affects these structures differently as well. So a child's head is proportionally larger than the adult and exerts greater stress on the neck structures during a deceleration injury. So also carefully assess the head and neck injury for injuries as well. With vehicle collisions, the area of greatest injury varies depending on the size of the child and the height of the bumper at the time of impact. So when the vehicle slows down at the moment of impact, the bumper dips slightly, causing the point of impact on the child to be lowered. So the area of struck depend on the height and the final position of the bumper at the time of the impact that actually happened. Children typically also sustain high energy injuries to the head, spine, abdomen, pelvis, and legs. As we talk about, they turn into the vehicle and they turn toward the oncoming vehicle as they see it approaching because they don't know what to do. These really sustain different than an adult who turns away. Excuse me. Head injuries are common in children. So the size of the child's head, remember, in relation to the body is definitely larger than the adults. And an infant has a softer, thinner skull, which may result in injury to the brain tissue. Remember, it's softer and thinner because it's giving room to expand as the child grows older. So the scalp and facial vessels can also bleed easily and may cause a great deal of blood loss if not controlled. Signs and symptoms are similar to the adult with some important differences. Nausea and vomiting are common in children. Easy to mistake for abdominal injuries or illness. Suspect a serious head injury in any child who experiences nausea and vomiting after a traumatic event. And pediatric patients are also managed in the same manner as an adult. Really nothing changes. Cervical spinal capnography, none of that stuff really changes as far as management goes. Understand that some of those signs and symptoms may be a little bit different. Immobilization, so necessary for all children who have possible head or spinal injuries after a traumatic event. So to immobilize the pediatric patient to a short backboard, look at skill drill 36-6. So mobilization also can be difficult because the child's body proportions as well. Young children require padding under the torso to maintain a neutral position. Around 8 to 10 years of age, though, the children no longer require padding underneath the torso. They can lie supine on the backboard. If the patient is unstable and has major injuries to the or the car seat is damaged, child must be removed from the car seat and immobilized on the backboard. If they're located in a car seat, usually we can transport them in, especially if they're an infant. We just transport them in the car seat they're currently in, unless there's significant damage to that. Right. If an appropriate size collar is not available, we can use towel rolls on each side to prevent side-to-side movement. So there are ways to spinally immobilize an infant in a car seat by padding on the sides and around the neck so the infant stays still. And we can utilize that as well. As far as chest injuries go, resulting in blunt trauma, as you can see to the chest here on the picture on the screen. So children have extremely soft, flexible ribs that can be compressed without breathing. A lot of the cartilage has not fully developed. The bones are not fully developed, so things are soft. So when you push on the chest, it crushes in and cause more internal injury to the lungs, to the heart as well. Even though there's no external injuries or signs of injuries, there may also be significant injuries within the chest. So we have to palpate, we have to auscultate, we have to listen and see what's going on, looking at our vital signs as well. Abdominal injuries are common in children and can have serious injury without external evidence of a problem. So monitor for signs of shock. Remain cautious about the possibility of internal injuries, even if the absence or with only a few signs and symptoms of shock. This is managed in the same manner as adults. So again, IV therapy, and then fluid resuscitation. Monitor the patient's condition during transport, monitoring vitals. Right. So as you can look here. So injuries to the extremities, obviously children have immature bones with active growth centers, the growth plates. The growth of long bones occur at the end of the specialized growth plates that are located. And we can go over more of that in depth on Sunday. So we're doing a lot of pediatric stuff on Sunday as well. So growth plates potentially are the weak spots in the bones, often injured as a result of trauma. So children's bones tend to bend more easily than those of adults. This is where we get that green stick fracture that happens. These are managed in the same way. Painful, deformed limbs, evidence of broken bones should be splinted. Whether you use a SAM splint, long board splints, air cast to vacuum splints, whatever you may utilize. Do not attempt to use adult mobilization devices unless a child is large enough to properly fit. Don't just toss the kid inside of it. Use ones that are designed for that child. As far as burns go, remember the rule of nines. It's very important in utilizing the Parkland formula to administer fluids, right? So children do not tolerate burns as well as adults do. More likely to go into shock, develop hypothermia, and experience airway problems. So I believe, if I remember correctly, and let me know if I'm wrong, I believe Laurel went over the Parkland formula with you guys. Did she end up doing that during med administration and stuff? Okay. I'm seeing yeses from Justin. Everybody else got that Parkland formula? Yes? No? Maybe? Anybody else still there? Okay. Good. All right. And we can definitely go over it again too. It wouldn't hurt to kind of cover it more than once. All right. So most common way for children in which children are burned are exposure to hot substances, hot items on a stove, exposure to any kind of caustic substance, suspect possible internal injuries from chemical ingestion as well, and looking around the mouth and nose. So we got to make sure we're looking inside the airway. If we have significant airway swelling, they're going to need to be intubated at some point if it's getting worse and worse. You're hearing that stridor sound as well. So infection is a common problem following a burn injury. So it needs to be managed appropriately. Obtain vascular access, preferably in a non-burned area. Administer 20 ml per kilogram bolus of normal saline or Ringer's solution if the child is in shock. Ringer's is great for burns because it helps replenish that electrolyte and that dehydration they're going to get, the hypothermia So we're going to give, warm fluids as well. So pull your IV therapy, your IV fluids off your warmer, administer warm fluids. That way we can prevent hypothermic. Patients follow hypothermia protocol, warming the patient back up again. Reassess and administer additional IV fluids as needed, and insert IO catheter if you're unable to attain IV access after, this is 3 tries or 90 seconds. 2 attempts or 90 seconds as per our protocols, right? But national registry is 3 attempts or 90 seconds for a critical patient. So fluid management, though, a circulatory compromise is less common in children than in adults as a result of trauma. So consider following when establishing vascular access, a large bore IV catheter should be inserted into a large peripheral vein whenever possible. 20 gauge catheters are considered large bore for pediatrics if you can get them in. Okay, do not start sinking 16 to 14 gauges into 2-year-olds, right? Not good. We don't even do those in adults. They're actually thinking about taking 14 gauges right off the ambulances. They've been talking about that for a while now within state protocols as far as using it for IV access. So to maintain perfusion, remember initial bolus of 20 mLs per kilo using an isotonic solution, then frequently reassess, right? If there's no improvements, we can do a second bolus. If the condition after 2 boluses of isotonic fluid, blood loss is likely severe. If we don't see any changes, it probably needs some surgical intervention. We have to maintain our blood pressure between 80 and 90 systolic. We do not want to put too much fluid in to a point where we end up making their blood turn into Kool-Aid, losing all those red blood cells. So that way we're going to lose the ability to push oxygen around the system. So manage that blood pressure appropriately, right? If you're getting blood pressures of 110 systolic, then we've already met that need. Stop pushing fluid, right? If you're starting to drop down to 90s to the 80s, we got to give a little bit more to kind of maintain. Let's do that, but don't flood a patient. All right. As far as pain management goes, positioning ice packs at extremity elevation are great for pain management. Utilize the Wong-Baker scale. If your service allows nitrous oxide, follow it per protocol. Nitrous oxide is not for pain management for anything in the abdominal cavity. It is for orthopedic use only. As far as triage goes, there's a jump start triage or start triage, and then there's a pediatric one. These were developed for pediatrics, the jump start pediatric system, intended for patients younger than 8 years of age and weighing less than 100 pounds. This will kind of cover a little bit of disaster management. So because infants and children may not be able to walk or follow commands during a disaster event, they must be considered for immediate delivery to the treatment area. There are 4 triage categories designated by colors corresponding with different levels of urgency. As we know, so we have green, yellow being delayed, red being immediate, and black being deceased. We'll cover more in operations later. We'll talk more about MCI management. So decision points include able to walk, except in infants, are green, yellow are more than delayed treatment, apneic patients and responsive to positioning or rescue breathing, respiratory failure, breathing but pulseless, or inappropriately responsive to painful stimuli are red. Apneic without a pulse or apneic with unresponsive to rescue breathing is considered black or deceased or expected to die. All right, so we're going to cover a little bit about child abuse and neglect. As you know, that there's 700,000 cases of child abuse reported on an annual basis in the United States on a yearly basis. Most of these children suffer life-threatening injuries and some do die. So if suspected child abuse is not reported, the abuse is likely to happen again, perhaps causing permanent injury or death. So be aware that you are mandated reporters. For those of you that work in Maine, I'm sure you guys already went through the mandated reporter training, didn't you? Right, the Maine providers. Yeah. It's a state requirement you go through it. So anybody that holds a Maine license technically is supposed to go through the mandated reporter training. And I believe they made it, Justin, correct me if I'm wrong, but it's a yearly thing now. If I remember correctly, I think it's yearly.
I do believe you're right.
Yeah, I think the state Maine EMS just changed that to a yearly thing now. So Record all findings, right? If you suspect abuse, physical or sexual abuse, ask, is the injury typical for the developmental level of the child? Is the method of injury reported consistent with the child's injuries? And is the patient or caregiver behaving appropriately, concerned about the child's well-being? I gave you my scenario, and there was definitely abuse going on because things just did not make any sense. Is there any evidence of drinking or drug abuse at the scene, at the home? Delayed in seeking child or care for the child. Was the leg broken for 2 days, and they decided to call 911. Is there a good relationship between the child and the parent or caregiver? Do they shy away, or do they come running towards you saying they love you or whatever it may be to the parent? Does the child have multiple injuries in different stages of healing, so the different coloration? Does the child have any several types of injuries such as bone burns, fractures, bruises, cigarette burns, things like that? As you can see here, you can see the different discolorations of bruising here to here to the back over here to the elbows to the buttocks down here. Burns to you can see these are burns to the feet. So obviously dipped in the boiling hot water, right? So look for those different signs and those different clues, right? Remember that these are the mnemonic child abuse shown in table 36-15, right? Over that there. Here's the excuse me, the table that's there for you to review. All right. So other burns on penis, testicles, vagina, buttocks are usually inflicted by someone else. They usually just don't burn. Suspected burn abuse of the child of cigarette burns or grid pattern burns on the back or whatever. Remember, these are going to be in places where the kids can still go to school and they can't be seen. So you have to expose. Right, take a look and see what's going on. Fractures of the humerus, femur do not normally occur without major trauma. Femurs just don't break, right, unless they have a predisposed condition. Falls from bed are not usually associated with fractures. They can fall out of bed. Kids are meant to bounce, right? So if they have broken bones, there's something significant that broke it, right? Shaken baby syndrome, infants may sustain life-threatening head trauma by being shaken or struck in the head. There's bleeding within the head or the damage to the cervical spine as well. Infants will be found unresponsive, often without evidence of external trauma. She may be called for an infant who has stopped breathing, or maybe appear to be in cardiopulmonary arrest. Neglect or refusal to failure on the part of the caregiver to provide life necessities. So you walk in, you find out they've had the same diaper on for the past 6 days. That's neglect, right? Skin and bones, no food in the house, or just hoarders. That's all neglect, okay? You've got to report this stuff. You cannot just let it go. Children are often dirty or too thin in appearance, or be developmentally delayed because of lack of stimulation. So again, we are mandated reporters. We have to report this kind of stuff. We see abuse and or neglect. Symptoms of other indicators of abuse would be abused children may also appear to be withdrawn, fearful, or hostile as well. So be concerned if a child refuses or to discuss how an injury occurred. They say, oh, my parents told me not to talk about it. Something's up. Red flags should be popping up in your head saying, this does not seem right. Right? Remember that we are mandated reporters. Right? The parents or caregivers may reveal a history of accidents. Well, it's an accident. It happens. Again, look at what's going on. If you have a 16-year-old male who has multiple different bruising patterns and he plays football, it's probably not going to be abuse. Again, talk to them, right? And then look at investigate it, okay? Because remember, people that play sports do get injured. Kids do fall all the time. They get bruised. But look at the different patterns, right? It's not just physical or what you can see, visual, I should say, but how they physically react with their parents as well. So you have to look at all that as different aspects. All right. So sexual abuse, obviously, most likely of rape or sexual abuse are females aged 16 to 19 years old, but children of any age of either sex can be subjected to sexual abuse. So assessment should be limited to determining the type of dressing any injuries require. Again, this is still it's evidence, right? So Do not examine any genitalia of young children unless there's evidence of bleeding. We need to control it to stop from them bleeding out, right? So there's evidence of blood and it's not bleeding significantly, and we can just kind of put something to collect the blood underneath it. That's fine. Never pack anything into a vagina. Never actually touch the penis of a male, right? Control, we need to control and transport, right? Potential for abuse, they need to be able to get evidence. No washing, urinating, defecating before a physician completes a physical exam. Nothing changes, right? They don't get to do anything. If possible, ensure that the AEMT or police officer of the same gender remains with the child. If you can do it, right? If you don't have a female present, it's a female, unfortunately you have to go. Now, if the patient requires ALS intervention and your partner's an EMT that's a male, or sorry, a female, and you're a male AEMT, there's a female issue and it requires ALS, you cannot abandon that patient. Okay, you have to be all back. You have to treat it. All right, to kind of finish up, the last 11 slides here is death of a child. So be prepared to offer the family a high level of support and understanding. Do not give false hope. The best you can, work the cardiac arrest, right? I've seen people just pick up the baby and start going to the ambulance, start transporting. That's perfectly fine. Just remember that if you're in the back of the ambulance, okay, this is me speaking as just a provider. You're going to be driving lights and sirens to the hospital. You're not buckled in the back. You're putting yourselves at danger as well. All right. Do the best you can with what you have. Transport, start CPR, airway management. And then be alert for signs of post-traumatic stress in yourself and others. Kid calls, kid fatalities are some of the worst calls you're ever going to go on. Right? Those are the things you don't forget. If any of you in the class have ever been to a pediatric arrest or have seen a pediatric trauma like that have turned into a fatality, you don't forget those. We don't have to discuss them, right? But there are people out there that can help you. The ISMs, things like that, protocols, diffusing, debriefing, available teams are available, someone to talk to. This is not the time or place to discuss it, but you've been on those calls before. Some of you have, and you don't forget them. They stay with you forever. SIDS, sudden infant death, 1,300 infant deaths were attributed to SIDS over the course of 2018. Where the mother, and this is impossible to predict SIDS, but risk factors include mother smoke during pregnancy or anyone smokes around the infant, low birth weight, or the baby is placed on the stomach in the crib or on a soft surface with loose bedding. They can suffocate. Death result of SIDS can occur any time of day. Usually discovered in the morning when parents or caregivers go to check on the infant in the morning after sleeping. Faced with 3 tasks, and one is the assessment of the scene, assessment and management of the patient, and communication and support of the family. So just be there for them as well. Scene safety. With this, death of a child, scene safety, carefully inspect the environment, noting the condition. Assessment should concentrate on signs of illness, including medications, humidifiers, thermometers, things like that. General condition of the house, signs of poor hygiene, family interaction, the site where the child was discovered, note all items in the crib or the bed as well, right? It's a crime scene at this point in time until otherwise ruled out. So everything has to be noted, documented. If you move something, you need to note what you moved. The diagnosis of exclusion, as far as assessment and management. Other potential causes may be ruled out by physicians. Accidental suffocation or strangulation in bed, overwhelming infection, child abuse, infection, meningitis, airway obstructions, and things like that. Accidental or intentional poisoning, hypoglycemia, congenital metabolic defects. So begin with the normal assessment. ABCDE is provide interventions as needed. Depending on how much time has passed, they may show signs of postmortem changes, including stiffening, rigor, blood pooling, lividity, dependent lividity. So the child shows these signs, call med control, and some EMS systems victims of SIDS may be declared dead on scene, decide whether to do CPR or not. So again, you have to call med control have a conversation, find out what the next step is going to be. Pay special attention to any marks or bruises on the child before performing any procedures, including CPR. Because remember, any CPR that is done by you can cause other bruising as well, or other bones to be broken, depending on how you do compressions and things like that. So again, also note any interventions such as CPR is done before your arrival. So if you walked in and you saw family doing CPR, you have to note that because there's going to be bruising where they're doing CPR. Communicate, always introduce yourself to the child's parents and caregivers and ask for the child's name, date of birth, medical history. If and when your decision is made to start or stop resuscitation efforts, inform the family immediately. Please don't just walk out of the house. Have one person go talk with the family. Do not speculate the cause of the child's death. It is not our job to do that. It's what medical examiners are for. Right? If they have any concerns, let them know that they'll be addressed, but the answers are not immediately available. So kind of work with that. The last part of this would be a BRUE, B-R-U-E, which is a brief, resolved, unexplained event. Infants who are not breathing and are cyanotic, unresponsive when found, sometimes resume breathing in colorless stimulation. This is called a classic BRUE, which is brief, resolved, unexplained event, characterized by a distinct change in muscle tone and choking or gagging. I can't tell you how many times I've gone to patients that have had BRUEs before. They're perfectly fine. After the event, the patient still needs to be transported to the hospital to find out why it happened. But after the event, the child may appear healthy and show no signs of distress. So if explained, or if asked, explain that you cannot say what caused the event, and it's something that the physician will have to determine in the hospital. So they're going to have to make that determination. So let me just stop this here. Any questions at all? I know this went for the full time.